Good morning, everybody. I think that's my cue. Good morning, everybody. So, Sharifa, we couldn't hear the sound on the video. Just an FYI, but no worries. We'll keep going. My name is Gerard Radivosian. I'm so happy to be with you all today. Good morning, good afternoon, and good evening to all of you. Thank you for making time to be with us. We're humbled by the overwhelming interest that we've had in today's workshop, and very keen to be hearing from each of you during our concurrent workshop hours. Let me also thank our staff at PEPFAR that have made this event possible. Crystal Solomon, who you heard from, Mark Mason, Sharifa Idris, and many others who you will not see on the screen, but have been instrumental in making this flow so smoothly today. The pursuit of health equity is a major policy priority of the United States, the Biden-Harris administration, and is a priority pillar that guides PEPFAR's work. And applying a health equity lens to our work has certain meaning, and with it comes implications for policy, for programming, and for financing. And so we're looking forward to exploring these themes in today's workshop. Sharif, if I can get the next slide, please. So we've got 3 goals for today's workshop. Goal 1 is to elevate the priority and the need for knowing and closing health equity gaps in the HIV response. Number 2 is to create an implementation agenda to tackle the opportunities and challenges ahead of us. PEPFAR has a new 5-year strategy which lays out the focus areas for this work, and we want to hear from you about how and what this implementation agenda should be. And our 3rd goal for that workshop is to explore new partnerships and collaborations with PEPFAR and other stakeholders. PEPFAR alone can't advance health equity. It takes a coordinated coalition of partnerships across countries, civil society organizations, foundations, faith-based organizations, private sector, and political leadership. And we've got all of those on the call today. Next slide, please. We have an ambitious 3-hour agenda. In the first plenary hour, we'll have 3 sets of panels. First, we'll hear from PEPFAR and Global AIDS leadership on why urgent action to closing equity gaps is critical to sustaining the HIV response, to protecting human rights, and to promoting economic and national security development. We'll then hear from a panel of U.S. government leaders on how equity is a major policy priority for this White House, for the State Department, and across this administration. Lastly, in our 3rd session on knowing gaps, closing gaps, we'll hear about how leveraging an equity lens for the HIV response and what that means. We'll hear from perspectives from the front lines, from leaders engaging on globally to fight discriminatory laws, build healthy families and communities, and ensuring the meaningful engagement of youth in all that we do. In our 2nd hour, this is the heart of the workshop. This is where we invite your perspectives, your ideas, your experiences, and recommendations to shape PEPFAR's implementation. We will have 3 concurrent workshops, as you heard from Crystal, with a facilitated dialogue and a set of questions to extract actionable recommendations for PEPFAR to close the major equity gaps that continue to block progress for key populations, for children, and for adolescent girls and young women. Next slide, please. And then in our final hour together, we'll reconvene in a plenary session that will include readouts from each of the workshop sessions and a panel of all-star U.S. government and PEPFAR interagency leadership about actioning the recommendations that you have all put forward. Next slide, please. The PEPFAR strategy is a launching pad for today's meeting. Everything we do today aligns directly with the 2022 PEPFAR strategy, which recognizes that without intentional focus on closing equity gaps, including addressing structural barriers and policies, the most vulnerable populations will continue to be left behind. You'll hear more about PEPFAR's strategy from our ambassador on all these priority focus areas in just a moment. Next slide, please. As I said at the outset, applying a health equity lens to our work has a certain meaning, and with it comes implications for policy, for programming, and for financing. So our speakers throughout the program today will reference equity and what it means to carry this work forward. And the commitment that we each should be making today is to ask ourselves, what are we going to do differently? Because we can't go back to business as usual tomorrow. So applying a health equity lens means asking ourselves, we've got a few questions here. I'll just read through them quickly. The first one is, who is experiencing the differences in outcomes and opportunities? Which communities and population groups are disadvantaged? Always thinking about who is not represented in the decision-making groups. Do we have the policies and programs to reflect community-informed and community-led solutions? Are we shifting resources to advance identified gaps? We have to ask ourselves, how am I advancing the values of diversity, inclusion, and equity? How am I proactively managing power inequities? The Lancet issue, which you see on the screen this month, focused on advancing racial and ethnic equity in health and highlighted that a core problem is in inequality in power. This includes an acknowledgement of racism, xenophobia, and discrimination that are fundamental determinants of health globally. We also have to ask ourselves, how are we measuring progress and what other data gaps exist? By no means is this list exhaustive, but as we go through the agenda and listen to our speakers and listen to each other in the breakout sessions, I invite you to reflect and build on these questions, because the commitment that we each should be making, as I said, is that we can't go back to business as usual tomorrow. Next slide, please. Placing health equity at the center of the global public health response requires adaptive leadership. And at the end of the day, adaptive leadership can only be addressed through changes in people's personal beliefs, priorities, and loyalties. This is work from Ron Heifetz and also Kamara Jones. And so what this means is that fighting inequities is ultimately about each of us being agents of change. And that requires humility, it requires self-reflection, letting go of loyalties that we may have to the status quo, being open to new and different ways of thinking, and new and different kinds of partnerships, and willingness to try new approaches. Next slide, please. And finally, I just want to end on a high note. While fighting structural and social barriers can seem daunting and almost paralyzing, there are plenty of examples around the world. And these three stories, just from this past week, from Barbados, from South Africa, and here from the United States, give us hope and confidence in our collective ability to prevail and to make the world just a little bit more just and just a little bit more healthy. So with that high note, it now gives me great pleasure to formally open today's workshop and begin our first panel. So for our first panel on why urgent action is critical, we will hear from three global leaders who have all prioritized equity in their respective organizations' response. We'll start with our PEPFAR ambassador, King Zong, who recently celebrated his 6th month in office. We'll then invite the executive director of the Global Fund, Peter Sands, to speak about the Global Fund's work to advance rights, gender, and equity on the heels of a very successful 7th replenishment. And third, we'll hear from Winnie Byanyima, who was kind enough to offer remarks even while she and her team have been busy in Bangkok this week for their annual PCB meeting. So without further ado, Ambassador King Zong, the floor is yours, sir.
Thank you, Gerard, and thanks colleagues who have really sacrificed a Friday afternoon or morning to attend this very important workshop on equity. Let me share with you a few slides just to help substantiate what Gerard just said. Some of those the narratives or outcome that he put forward. I think we've all agreed that data leadership is the way to go so that we know exactly how to fight this fight. So what I would do is in the next few minutes, really few minutes, share with you some specifics of what that inequality looks like in different populations. Next slide. The next one. Next. So as you all are aware, we released the PEPFAR's strategy, the next 5-year strategy on December 1st, which was a result of how we call on various stakeholders, including most of you who are on here, to reimagine a strategic direction to accelerating the response to end HIV/AIDS pandemic as a public health threat by the year 2030, while sustainably strengthening public health systems. That has remained a purpose statement. Next slide. To do that, I think Gerard also talked about the need to be humble and respect, because if we apply those, then we also have to ensure that we listen carefully. And humility here, especially in the context of what we are discussing today, doesn't mean that we think less of ourselves, but it's thinking of ourselves less all the time. And so that we can listen truly, listen to each other and understand each other, is to address these gaps. Equity is key. Our accountability and transparency, impact, and sustained engagement. Those 5 areas will continue to be the principles, the guiding principles on how we advance our PEPFAR strategy. Next slide. These are the 5 pillars of the new strategy, which again, you've all read it. I will not repeat it, but I just wanted to use this single slide to kind of remind you, refresh you where we are. There are 5 pillars. Pillar number 1 is the health equity. Number 2 is sustaining the response. And the pillar number 3 is public health systems. Pillar 4 is partnerships. And pillar number 5 is following the science. The cross-cutting enablers are leading with data, innovation, and community leadership. That's in short. If you've not read the 5-year strategic plan, this slide captures and summarizes all of that brilliantly. Next slide. So let's focus on the first pillar, which is the equity or inequity pillar. Underneath that pillar, there are 3 priority populations that we all agree that we should look at carefully. First is adolescent girls and young women. Second is children. And third is key population, including men who have sex with men, female sex workers, transgender people, people who inject drugs, and people in prison. If you look at these 3 populations, the cross-cutting underpinning that we have to look at a combination prevention approach, a holistic method to ensure that in as much as we advance treatment, we also double down on prevention. We also look at ways to dismantle the barriers that create the inequalities and inequities in these different populations, both in terms of policy, programmatic, social, and structural barriers. Next slide. Perhaps the best way to substantiate what the issues are is to look at some data. And this is a slide that we borrow from, as we all do, from UNAIDS. The gray chart there shows you HIV/AIDS in adolescent girls and young women, and the red adolescent boys. And just seeing the label again, that is what it is. The red, yeah, good, thank you. The red is the adolescent boys and young women, and then the gray, I mean, clearly, this is what we call evident evidence. There is no need to interpret that. It's obvious. You see that from 2010 to 2021, even though we've seen a steady decline across that population group, the young people, the numbers are just dramatic. And as I said, 3 times rate of new infections in adolescent girls and young women than in adolescent boys and young men. Next slide. If you now shift to, and again, try to take the major, I don't know if it's from my screen, but I think others are having the same problems, I think. The titles, I mean, and then the bottom part of it is blacking out and they can't read that. But essentially it says major gaps in viral suppression in children and compared to adults. So what you see here is on your vertical axis, the viral load suppression in percentage, and the horizontal axis is the years, I mean, the trends over a couple of years. You clearly see that in yellow or orange children, and then in red, viral load suppression in adults. And over the years, we've made some progress in terms of suppressing viremia in adults, but look at the curve, the orange curves in children, almost like we are stagnating. And it ranges from 26% to 41%, but I could almost say that, look at the rate of change is almost a constant. So I think that is, if you're looking for a definition of inequity, that is it right there in front of you in children. Next slide. To address that gap, just the other week, I was privileged to join the Rome Action Plan meeting, where the issues around closing the gaps of equity in children was discussed. And I'm really hoping that the next time, next year, when we all gather in Rome, some very specific actions would have taken that would begin to change that some of those slides that I showed on the screen. And we all took our commitments. Those of us who were there took commitments to begin to change that outlook. Next slide. If you now look at inequities in key populations, and you look at Zimbabwe, and this is a very interesting slide. It shows you three categories of populations. One is all adult population, that is 15 years and above. And then the middle slide there, light green, shows you the gay men and other men who have sex with men. And then the third category, if you, again, take out the black line, please, the black thing at the bottom. But essentially, thank you. It shows transgender women and individuals. Very, very interesting. This is a remarkable slide. It shows you the inequities in, especially in people who are living with HIV/AIDS and know their status, or rather flip it and say do not know their status. And the middle set of bars is very interesting. It says that, at least in my interpretation, that once we can identify those groups, there is really relatively easy to put them on treatment, regardless of which category of population they are, whether they are adults, gay men, and other populations. And then viral load suppression just follows through there. So the first set of the 95 really tells you that we have some work to do in that area there. I think there's a chart that says also remove the top dark bar, please. It's really making it difficult for people to read. Next slide. And moving to another area, and this is again key populations in looking at Vietnam in this case, and different subgroups, female sex workers, men who have sex with men, and again, going by the first 95, second 95, and third 95. For female sex workers, you are reading that number in red correctly, that for that subgroup of people, only 33% of them know their status. If you are looking for inequalities or inequities, that is it right there in front of you. And then men who have sex with men. Again, feeding into that narrative that it's difficult for us. That is a big challenge we have on our hands. And if you look at the second 95, it's 100%, which means that once we have successfully identified those who are HIV positive, we can put them on treatment. And again, with that same interpretation, you can read through the challenges we have in other populations in different cities in Vietnam. Next slide. Eswatini is an interesting scenario where you also have a wide variety of differences of men who have sex with men, female sex workers. But here you see that the situation in Eswatini almost mirrors the overall population, where 84% of men who have sex with men, female sex workers, do have approaching the 95, the first 95. And the second 95, they're all exceeding that. And then the third 95 is very, very similar. So the situation, the overall situation in the general population in Eswatini mirrors what you see in key population. That's not true in Ghana. It just shows you the variety, how different countries are approaching this. And that's why it's such a dialogue, like what we're having today, makes sense for us to share experiences across different countries. Next slide. Let me just conclude with 3 questions that I have. It's unusual to conclude with questions, but let me do it for the sake of this conversation. Again, reiterate that the purpose of this workshop, which is the first of a series of workshops, is to begin to look at an implementation strategy on how do we move our the 5-year strategy that was released just a few days ago forward. We are not looking to co-create new priorities, but to say how, to focus on the hows and learn the best practices there. So first question is, how can we close the gaps? The second question is, are there best practices out there? Like Eswatini, we just saw the data. What is it that Eswatini is doing that Vietnam can learn from? And where do we want to be 5 years from now, so that we do not, again, bring ourselves together and we're still discussing issues related to inequality and inequities. I think that's my concluding slide. Thank you all, and I look forward to a very engaging and constructive conversation.
Ambassador, thank you so much for your leadership. Thanks for the equity focus that you have brought to PEPFAR from your first day in office, and we look forward to your reflections during the closing plenary later on this morning. So we'll now hear from Peter Sands, the Executive Director of the Global Fund. Peter, thanks to you as well for your tremendous leadership and for shepherding equity within the Global Fund's strategic plan. We look forward to hearing from you. Welcome, sir. The floor is yours.
Thank you, Jura, and it's a real privilege to have the opportunity to participate in what I think is a very timely workshop on health equity. And as always, it's a real pleasure to follow you, John. You always not only say what I was struggling to work out how to say, but you say it better than I would have said it. Which leaves me with a little bit of a challenge now in working out what more to add. But here's a few observations. First of all, the reason health equity is so important, even more important for HIV/AIDS than it is for all the other issues in global health, is that the epidemiology of this pandemic is driven by inequities. We have the tools to beat HIV/AIDS. Yes, we would like better tools. We would like a vaccine, we would like a cure. But the reality is we have very powerful tools, antiretrovirals that work and can fully suppress the virus, things like PrEP that can prevent people getting infected. These are powerful tools. And we know from real life experience in high-income countries that have taken this route, that if you remove inequities, you can achieve the goal of ending HIV/AIDS as a public health threat. And in the high-income countries that don't remove the inequities, they fail. They don't succeed in removing HIV/AIDS as a public health threat. So it is an absolute imperative, if we are serious, and we are, about achieving this objective, that we, to use the language you started with, Gerard, we know and we close the inequities. However, this is not easy. It's not easy for a number of reasons. First is we have to know them. And I think there have been huge advances in the amount of data, the kinds of things John was just showing that reveal the scale of inequities. But I think every time we look at this, we discover that we need to get even more granular, that within the inequities, there are yet further inequities, and that we have to unpick these to really be able to focus our efforts. A second challenge is that we have to be prepared to go beyond the biomedical. That if we just rely on supplying more drugs to those populations who seem not to have had access to them, we won't succeed, we have to be prepared to work in partnership to address the root causes of inequities, whether these are legal, political, socio-cultural, whatever it is that is driving them. And doing that takes many in the global health community, in a sense, a little bit out of the comfort zone. And it also means we have to be prepared to have some very uncomfortable discussions, challenging beliefs or political perceptions about what can be done and what is tolerated in terms of behaviors and attitudes. Now, actually, I think we have a massive opportunity right now. We have, as John laid out, and I've got it in front of me, a new strategy from PEPFAR, and we have an equally new strategy from the Global Fund. And both of them put far greater, much more intense emphasis on tackling human rights related barriers, gender inequalities, inequities more generally. And that's great, because that provides a framing then for the very operational work that, again, we are both embarked on. We'll have the new cycle of Global Fund grants, the whole funding request process. We're just beginning to send out the country allocation letters, is about to kick off. And simultaneously, you'll have COP23. And so there's a real opportunity for PEPFAR and the Global Fund to work together very closely on how we operationalize these ambitions. And we can also use our voices collectively. I think our voice on the policy issues in country is incredibly important, because there's only so much we can do. Yes, it's incredibly important that our programming is responsive to the inequities, and we have put new guidance around health inequities into the guidance for funding requests. We're also introducing a gender marker for our programming. These are all important enhancements to the way we're thinking about the grants that we deliver and the programs that they result in. But we also need to be working with country partners on the policy side of it. Because if we don't tackle issues around criminalization or effective policy reinforcement of stigma and discrimination, there's only so much we can do through the programming. Critical to all of this is the effective engagement of the communities themselves, those who are on the wrong end of these inequities. Because to turn the data into real understanding of what is going on and what the root causes are, you need the voices of the people who are most directly affected. And actually, to close the gaps, to address and tackle them, you need the leadership of those same communities. So this is, I think, a really critical point against the fight against HIV/AIDS, where we do need to intensify our focus on inequities. We at the Global Fund are absolutely determined to stand shoulder to shoulder with PEPFAR in this. And we do see it as part of a broader partnership effort, which will require action by governments, because ultimately some of the things require changes in legislation, but also action at the absolute grassroots level in tackling the day-to-day realities, the real barriers that many communities face. So with that, I'll hand back to you, Gerard. But as I say, I think this is a very timely discussion.
Thank you so much, Peter. Loved your framing of coming outside of our comfort zones, and which I know will be a recurring theme for us throughout the workshop. So thank you so much for your commitment and your partnership for so many years. Our next speaker is Winnie Bianima from UNAIDS, who this month started a campaign called Equalize, which is a call to action for all of us to prioritize equity. And as I said at the outset, Winnie was kind enough to submit a video while she and the team are in Bangkok as we speak for the UNAIDS PCB meeting. So let's cue up the video, please.
Good morning. It's my honor to join Ambassador John Kengasong and Peter Sands to open this workshop on how PEPFAR can advance health equity. Congratulations, Ambassador Kengasong and your entire team at PEPFAR on your 20th anniversary. PEPFAR has saved millions of lives. You should be proud. On the eve of World AIDS Day, UNAIDS sounded the alarm. Dangerous inequalities are undermining the AIDS response and jeopardizing the health security of everyone. The new PEPFAR Five-year Strategy, which you launched on World AIDS Day, is the boldest and most transformative strategy in the history of PEPFAR, further advancing United States leadership to end AIDS. Today, PEPFAR is taking a major step forward by making health equity the first priority pillar in your new strategy. You're building on the commitment of the Biden administration to advance equity as a priority for U.S. domestic and foreign policy. I can imagine what PEPFAR will achieve with an equity lens to guide its billions of annual investments in HIV. With an equity lens, you will be better able to identify and close the gaps in service delivery and help to end new infections for priority populations. I know that today, UNAIDS staff and UNAIDS offices in PEPFAR countries around the world are participating in this workshop. John, you have our commitment that UNAIDS will work with you. Together, we are going to ensure all our girls are empowered to protect themselves from HIV. We're going to ensure that every child living with HIV is diagnosed and put on treatment, and we will end pediatric AIDS once and for all. We will ensure that all people living with HIV, everyone in same-sex relationships, all sex workers, and all people who use drugs are no longer left behind. Together with PEPFAR, with the Global Fund, with us, the United Nations, supporting partner countries and communities, we will close the gaps and we will end AIDS. Thank you very much. Happy meeting. Good results.
This is UNAIDS.
Okay, well, thank you to Winnie and her fabulous team. That concludes a very powerful trinity of global AIDS leaders and the equity that they bring to the work every single day. So we thank them for their support. Colleagues, we're running just 20 minutes behind schedule. I'm sure we'll make up for it as the day moves forward. So thank you all for your patience with just a little bit of some technical difficulty. But we're going to move forward now to our second panel on equity as a U.S. policy priority. We have an amazing lineup of U.S. government leaders who have joined us today. I think I see them all on the screen. These four leaders will demonstrate how they put health equity to action on behalf of the U.S. government, and we've asked each to reflect on how this major U.S. policy priority can apply to PEPFAR. So first, we'll hear from U.S. Ambassador Randy Berry, who just recently arrived to Namibia. And when I say recently, I mean this week. Throughout his career, he's been a staunch defender of rights and equity, Prior to arriving to Namibia, he was our U.S. ambassador to Nepal, as well as the first U.S. special envoy for the human rights of LGBTQI persons from 2015 to 2017. What a treat for us to have you here, sir. Welcome, Ambassador.
Thank you so much, Herrera, and I hope you can hear me. We've been experiencing a little bit of technical problems as well. I'm really honored to have just a couple of minutes to speak to the issue of equity, and I'm equally humbled to be on a panel with some folks that I have known for years and respect so greatly. As Herrera mentioned, I arrived in Namibia just 72 hours ago, so I'm hardly an expert on things Namibia, but after 30 years in the Foreign Service, I've had, unfortunately, too many opportunities to see what inequity does on so many of our priority policies and so many of the values that we seek to advance through our international efforts. In settings ranging from rural and urban settlements to refugee displaced communities across South Asia and Africa, where I've spent much of my career. It's absolutely clear to me that this great inequity is at the root of everything that we seek to advance, that brings true equality into the picture as a long-term objective, affecting our engagement on education, on human rights, on human development, on so many other issues. So I think what that means for persons like myself in a leadership position is it becomes a priority. It becomes vital to continue to take a look at this issue of inequity across everything that we do. We're having an opportunity here today, obviously, to discuss about what that does to our efforts to engage and improve health outcomes. But in fact, it's so much broader than that, and such an intricate puzzle. So I would say that, here in Namibia, I'm getting to know the country, but I can see already the signs that I already know well. As the second most unequal country in the world in terms of income inequality, gross income inequality carries with it the destabilizing effect in everything we see, from food security, education, and health. We see inequity right here in Namibia along the lines of gender, race, sexual orientation, gender identity, tribal group, geographic area, and even these rural-urban divides. So, I think the terminology often makes it difficult for us to really come to terms with how we combat inequity in a systemic sort of way, because, for example, Namibia is also classified as an upper middle income country by the World Bank, which in turn denies it easy access to resources, to development assistance, and to concessional loans required to address some of those structural issues entrenching some of these inequalities. So I think what that does is it puts a priority on engaging in complex manners and understanding that there's a great deal of significance which lies behind or below some of these easy labels. We also see in the U.S., in Namibia, and most of the countries where I've served over the course of my career in Bangladesh, in Nepal, in Uganda, South Africa, social inequalities such as stigma and discrimination have a significant impact on our ability to engage on health. You all would know better than I do that stigma complicates achieving epidemic control and just makes it that much harder to sustain it. So if we truly care about health security, if we care about real justice, we have to continue to identify those most vulnerable to stigma, and we have to combat that. In HIV, this is particularly relevant for those most heavily impacted, including those categories that have been discussed a little bit earlier. But I think also we must work to advance equity and access to economic equality, to educational and political opportunity, as well as to access justice and human rights, and the power to advocate for change when needs, in fact, aren't met. So, if we only focus on health inequities, we're never going to shape, I think, sustainable systems unless we are tackling these other roots where inequity is impacting so negatively. So I think that, the way we see this play out in a place like Namibia and also in Nepal during my previous service, that if you look at issues like food security and how inequities affect food security, that also impacts people who may not even be able to take their ARVs every day because of a lack of nutrition to accompany that. So, here in Nepal or here in Namibia, we have partnered with the World Food Program, for example, in their integrated community-based food systems in geographic areas, serving folks who are at the bottom end of this tragic ladder. So again, I think it's just a call for me and a reminder to me and all of us to take a broad look at this, to make sure that we are advancing policies that both policies and programs and interventions that are aimed at tackling broad inequity, health systems among them. That I think this is a very long-term, very complex commitment. But if we're going to tackle this systematic exclusion of individuals and groups from participating fully in society, we've got to go to those root causes and advocate for this every day. And with that, Gerard, I'm going to turn it back to you.
Thank you so much, Ambassador. You may be new to Namibia, but anyone who just heard you speak knows that you're not new to these issues. Thank you for so eloquently describing the interconnected and intersectoral elements related to equity more broadly. And thank you for your leadership on behalf of the United States in Namibia and at the front lines. And we look forward to continuing to partner with you once you get your feet settled on Namibia. So thank you again for making time to be with us, sir. So second, we'll hear from U.S. Special Envoy Jessica Stern. She has the longest title in the United States government, which is very fitting for the monumental leadership that she provides to the State Department and this administration on advancing the rights of LGBTQI persons. Prior to joining the Biden-Harris administration in 2021, she was the executive director for Outright Action International for 10 years and has always just been a passionate advocate for advancing justice. Jessica, thank you so much for being with us. The floor is yours.
Thank you so much, Gerard. Can you hear me clearly?
Yes, ma'am. Loud and clear.
I don't know if I have the longest title in all of government, but the Secretary of State tells me I have the longest title in the Department of State. And considering how crazy the Department of State is, that says a lot. But Gerard is right. When you're fighting for the rights of LGBTQI plus persons, you want to take up space. So good morning, good afternoon, good evening to everyone. It's great to be in this space with you. Thank you, Gerard, for the introduction, and thank you, Ambassador and King Asang, for the incredibly important work that you do to elevate health equity on behalf of the Biden-Harris administration. I'm reflecting on the concept of time. And for many of us, December can be an emotional month. Holidays are on the horizon, which carries the good and the bad with it. We honor the solemnity of World AIDS Day, and we celebrate the Power of Human Rights Day. And I think these occasions are fitting anchors to today's event. And from a personal perspective, I'm actually thinking about a longer horizon. On Tuesday, I was fortunate to join maybe 2,000 allies at the White House when President Biden signed the Respect for Marriage Act, ensuring that the marriages of same-sex and interracial couples cannot be nullified by state action. While marriage equality is not the only priority for LGBTQI+ or civil rights movements, nor a goal for every person, it's one incredibly important component of legal equality in a broader agenda for rights and recognition. So this week, I'm reflecting on how tenacious activists, like many of the people on the call today, know how to move mountains and produce transformative change, and how we in government are better when we listen to you and follow your lead. As Special Envoy, there are 3 points I want to make today. First, while foreign assistance should not be dependent on progress on human rights has a positive effect on public health and ensures that taxpayer dollars are spent effectively in both areas. Second, while our missions are distinct, PEPFAR should engage the LGBTQI+ community and other key affected populations even closer than we historically have in order to succeed. And third, LGBTQI+ community organizations need financial and capacity strengthening resources, and PEPFAR is well positioned to provide those and should. I know that we're in alignment on this point in particular because I see these concepts clearly reflected in PEPFAR's recently released 5-year strategy. So on the first point, the Biden-Harris administration has placed the promotion of respect for the human rights of LGBTQI+ persons and all persons as part of a strong, inclusive democracy at the center of its policy, as Tuesday's legislation makes clear. The administration has directed all U.S. foreign affairs agencies to, quote, consider the impact of programs by the federal government on human rights, including the rights of LGBTQI+ persons when making funding decisions. In short, this is a robust endorsement of the long-term process of engaging LGBTQI+ persons and other key affected populations. We cannot turn a blind eye when governments unfairly target LGBTQI+ persons and then expect to increase peace and prosperity or bring the global epidemic of HIV and AIDS to an end. As I'm sure everyone here knows, suppressing the LGBTQI+ community has dramatically negative effects on public health to the detriment of all. And I think Ambassador Nkengasong's slides made that very clear. And for the Americans on the line today, when we overlook LGBTQI populations, we waste taxpayer dollars because we are ineffective in our efforts to end HIV and AIDS. In short, we must expand our efforts to promote respect for the human rights of all persons, including LGBTQI+ persons, by combating discrimination and stigma. Second, I want to emphasize the importance for us in the US government and all of us in the global effort to tackle HIV and AIDS to redouble our efforts to develop closer ties to LGBTQI+ people in every country. Though the data isn't new, I am still astounded when I read that key populations account for over half of all new infections. And many of us know the study that argues that only 2% of all HIV/AIDS funding targets key populations. I know that study has been debated, and I sincerely hope that it's wrong, but there's no question that it should generate healthy debate and absolutely mandate greater scrutiny in the budgeting process. Ending HIV/AIDS as a public health threat means stopping new infections, and this is particularly essential for the most marginalized, stigmatized, and criminalized groups like key populations. And I just want to emphasize the value of working through the Key POPs framework. And I don't often hear in other human rights spaces enough emphasis on gay and bisexual men and other men who have sex with men. I don't hear enough focus on transgender people, especially transgender women. I don't hear enough focus on sex workers, IV drug users, people who are incarcerated, and others. So the value that we have in this space is not only to tackle HIV and AIDS, but also to lift up and elevate people that are so often excluded and overlooked. So third, I want to talk about money. Everybody wants it and nobody has enough, except for maybe a couple of tech billionaires. Global philanthropic funding for LGBTQI+ issues reached $576 million annually in 2020. So you may be thinking, that sounds like a lot. But when you look at the data, the picture is more complicated. Only 35 cents out of every $100 of total foundation grant dollars goes to support LGBTQI rights. And of that tiny percentage, only 1/3 is directed to the Global South and East, meaning that LGBTQI+ organizations in low-income countries are quite literally starved of financial and institutional resources. And so I think it should be obvious why we struggle to tackle the root causes that drive the epidemic. And so I want to encourage all donors in this space to better resource community-based LGBTQI+ organizations, especially in the Global South and East. Strengthen them as partners because they know exactly how to advocate for themselves. As I conclude, I want to share a personal reflection. I travel often, averaging maybe 3 countries a month. And everywhere I go, the first visits I make are to LGBTQIA human rights defenders and organizations. And I am awed by how they move mountains. But I am also clear that they do it in the face of enormous structural opposition. They have small budgets, their staff and members are harassed, their NGOs are often denied access to legal registration, foreign funding laws restrict their access to funding, and their own governments often won't meet with them, maybe if they're lucky, the Ministry of Health. But even then, it can be challenging. And so when Ambassador Nkengasong asks, how do we close the gaps and what are the best practices? I want to underscore that from my position, one of the most important solutions is investing in community-based organizations on the front lines. So I'll draw to a conclusion, and I just want to really honor the fight of so many people who came before us, and so many people, I think I last saw there are over 400 people on the call, who work together on this agenda, who work to hold governments accountable, who work to hold us in the US government accountable, and have helped bring us to this point. And yes, I think we must direct more of our precious financial, technical, and institutional resources to LGBTQI+ and KPOPs organizations, because it will make us all richer for it. Thanks so much, and back to you, Gerard.
Thank you so much, Special Envoy Stern, for that clear call to action. Thank you for being a strong voice for human rights in our department and on behalf of the U.S. government. Thank you for your words and for being here. I'm going to turn over to now Harold Phillips. Harold Phillips is a friend to all of us on this call and a leader in both the domestic and global HIV efforts. Harold, you're uniquely positioned to understand the interconnectedness of inequities that persist in not only the U.S. response here at home, but the ones that persist internationally as well, that Ambassador Nkengasong and Ambassador Barry and Jessica have already mentioned. So I'll turn it over to you, Harold. I know you're driving to the office, but thanks for being with us.
Thanks, Gerard. Hopefully you can hear me okay. Yes?
Yes.
Great. So I'm actually not driving, but this is such an important discussion that I did not want to be defeated by Washington, D.C. traffic, nor Washington, D.C. construction. So I have pulled over and parked in a safe space where I can give my remarks and participate in the panel. So good morning, good afternoon, and good evening to those of you who have joined us today. And I would like to thank Ambassador Nkengasong, Peter and Winnie, and you, Gerard, for ensuring that there is some focus on both what we're doing here in the United States to address some of the inequalities that may be helpful to our global partners as we work collectively to end the HIV epidemic. I'd also like to say congratulations to the PEPFAR team on the new 5-year strategy that pulls all of this together. You know, the Biden administration's focus on collaborations between our international and domestic HIV response, along with the Department of Health and Human Services and PEPFAR in the State Department, is something that I'm very proud of and believe will help us further our efforts collectively to end the HIV epidemic. On his first day in office, President Biden signed an executive order on advancing racial equity and support for underserved communities. And in February of 2021, he signed a memorandum on advancing the human rights of LGBTQ+I+ individuals around the world. And to mark Pride Month in 2020, the president signed the most significant executive order on LGBTQI+ civil rights in history. Among other actions, this order strengthened federal coordination to improve health equity by protecting LGBTQ+I+ individuals' access to health services, addressing the risk of so-called conversion therapy, and driving better data collection on individuals' sexual orientation and gender identity to increase the visibility of the populations and better serve their needs. And as Special Envoy Stern mentioned on Tuesday, the significant and historic and emotionally moving signing of the Respect for Marriage Act at the White House, joined by thousands of individuals who have worked on this issue and individuals who are touched by this issue and their lives and families impacted. In addition, the administration has launched the first ever White House Interagency Working Group on Violence Against Transgender Americans, which released a federal report and blueprint of actions agencies are taking to address the root causes of violence against transgender women of color. In June of 2022, one of our federal agencies released a letter encouraging the Ryan White HIV/AIDS program service providers. These are the largest network of service providers in the United States providing HIV care to those who are HIV positive. The letter encouraged them to leverage their infrastructure to provide access to gender-affirming care and treatment services for transgender and gender-diverse populations with HIV. Our own national HIV/AIDS strategy, which we released in December of 2021, aligns in many ways with the new PEPFAR Five-year Strategy. And one of those ways is the consistent and intentional focus on equity. One of the things I'm most proud of in this new national strategy is the acknowledgement for the first time that racism is a serious public health threat affecting the well-being of millions of Americans and also a driver of HIV health outcomes. It acknowledges that the systems and structures that we have created in this country for over 200 years do not work well for everyone and do not help it and do not provide access in equal ways. The national strategy uses HIV incidence data to identify the priority populations on which we need to focus our HIV response in the United States. Very similar to the presentation that the ambassador presented this morning, and encouraging one to look at the data and become granular in the approach of understanding where disparities truly exist. In the United States, our epidemic is marked by significant disparities. Among all new infections in the year 2019, 42% were among Black or African American individuals, and 25% were among Hispanic and Latinx individuals. And while only 19% of our new diagnoses in 2019 were among women, 54% of those women were Black and African American women. Additionally, the majority of new HIV diagnoses amongst transgender women were Black and African American transgender women and Hispanic and Latino at 46% and 35% respectively. We know also that gay and bisexual men and other men who have sex with men are disproportionately impacted by HIV, as people who inject drugs and people who live in the southern region of the United States. So we also not only are looking at population-based, but geographic-based disparities in our approach toward equity. In the United States, we have an equity initiative that began in 2019, the Ending the HIV Epidemic in the US, which gave additional financial resources and technical assistance to 57 areas in the country where we are seeing the greatest number of new HIV diagnoses. While the initiative was slow due to COVID-19, we've also seen tremendous progress with almost 20,000 new clients newly engaged or re-engaged in HIV care, and over 80,000 people linked to PrEP access through our community health centers. I'm also very clear that we must continue to center our equity response by inclusion of people with lived experience to be at the forefront of creating and implementing policies and programs that are purported to serve these populations. We emphasize this throughout the national HIV/AIDS strategy and planning components of our Ending the HIV Epidemic. There are several examples of how this approach is successful. I'd also like to think that I'm one of those examples as a gay man living with HIV and serving in this capacity in the White House as our Director of National AIDS Policy. But a more recent example is our approach to and the recent success of addressing the Mpox epidemic in the United States. The use and engagement of those with lived experiences, helping us to eliminate the barriers to prevention and treatment of Mpox. Both mobile and pop-up vaccinations, People with lived experiences were involved in the planning and the delivery and addressing the stigma. Also helping us to think creatively about ways to change the name of the disease to help reduce stigma, and then also helping us craft messages and partner with the U.S. government in becoming as a trusted messenger to deliver key messages to various populations impacted by the mpox epidemic. I'm happy to say that because of a lot of these efforts, in the last week, we've seen in the last couple of weeks, we've seen continued decreases in the number of new cases. And now we have about 7 as of the last reported date in the entire United States. So that approach to equity and centering equity has proven successful in the way we've addressed it. And I know we can do it in the United States. We must continue to center equity in developing all of our programs and policies as part of our HIV response. And if we do not put health equity foremost, it is obvious that we run the risk of leaving out some of our most impacted populations. By using health equity as a factor when crafting policy, program, and research, we ensure that we're taking into account the social and structural determinants of health, such as racism, employment opportunities, healthcare coverage, access to housing, transportation, food, medical mistrust, stigma, and discrimination. As I often say, we will have not ended the epidemic in the United States if we don't end the epidemic for everyone in every place. We will not be able to truly implement policies and programs that contribute to ending the HIV epidemic if we do not center health equity and the communities most impacted by the HIV epidemic. Thank you.
Thanks so much, Harold. We are so lucky to have you in the White House leading our domestic HIV response and being an important bridge to our efforts globally at the State Department. Thanks for making time and for pulling over to join us this morning. I'm going to turn it over now to our fourth speaker in the series here, Rachel Vogelstein. We're so lucky to have Rachel, who is a staunch advocate for gender equality and gender equity for this administration. She serves as a special assistant to the president on the Gender Policy Council. And for over a decade, she served as an advisor to Secretary Hillary Clinton on women's issues, and in the Obama administration, also served in the State Department, where she helped develop landmark foreign policy legislation on women's empowerment. And she continues that work for the Biden-Harris administration and will be sharing priorities as it relates to gender equality and gender equity. Rachel, thank you, and over to you.
Thank you so much, Gerard, and thank you to the Office of the Global AIDS Coordinator and Health Diplomacy for organizing this important convening and for inviting me to join. I'm honored to be here with our U.S. Global AIDS Coordinator, Ambassador Nkang Song, and other leaders, and very pleased to be joining my co-panelists and U.S. government colleagues. I'm delighted to speak on behalf of the Gender Policy Council and the National Security Council at the White House, where I am dual-hatted and focused on gender equity and equality. My colleagues at the Office of the Global AIDS Coordinator have long taken the lead in integrating a focus on equity into global health programs, and nothing exemplifies this commitment more than PEPFAR's multi-year sustained commitment to the DREAMS initiative. As many of you know, DREAMS takes a comprehensive view of the disproportionate impact of HIV and AIDS on young girls and adolescent women, and importantly for our discussion today, actively addresses those challenges. Advancing gender equity and equality is a priority not only for PEPFAR, but across the work of the Biden-Harris administration. When President Biden assumed office, he signed an executive order establishing the first ever Gender Policy Council here at the White House with a mandate to advance a focus on gender equity and equality through both our domestic and our foreign policy. And this same executive order also mandated the creation of our first ever national strategy on gender equity and equality, which was released last year. The National Gender Strategy affirms our commitment to advance gender equity and equality both at home and abroad as a moral and as a strategic imperative. It outlines a comprehensive government-wide approach and guides the work of all federal departments and agencies, including those focused on advancing our national security and foreign policy interests. And it identifies 10 strategic priorities that are intentionally broad in scope and cover a range of domestic and global policy issues, including health, which of course includes sexual and reproductive health and rights. The National Gender Strategy itself builds on and complements the administration's broader equity agenda, including on racial equity, the human rights of LGBTQI+ people, international religious freedom, and the rights of persons with disabilities. And the strategy adopts an intersectional approach that considers the barriers and challenges faced by those who experience intersecting and compounding forms of discrimination and bias. It's important to underscore that the strategy is accompanied by an unprecedented request in resources. President Biden's fiscal year 2023 budget requests included approximately $2.6 billion for foreign assistance programs that promote gender equity and equality worldwide, more than doubling the amount requested for gender programs in the fiscal year 2022 budget. This included a request for $200 million for the Gender Equity and Equality Action Fund, which is an important mechanism for supporting critical gender equality programs around the world. The National Gender Strategy not only identifies domestic and international policy priorities, but it also outlines a plan for implementation, requiring every agency to complete an action plan articulating top goals and furtherance of the strategy. And importantly, the Department of State's action plan under the National Gender Strategy includes a specific goal on achieving equitable access to and participation in HIV prevention and treatment services in PEPFAR countries. My colleagues with us today from the Office of the Global AIDS Coordinator are working to accomplish this goal by ensuring that PEPFAR programming addresses gaps and disparities in services based on gender. The Department of State also released revised PEPFAR programmatic guidance for fiscal year 2023 that included a focus on gender equality and equitable services for HIV prevention and treatment, as I'm sure we'll talk more about today. And in response to President Biden's request, PEPFAR expects to report more than $100 million in additional resources to advance gender equality and prevent and respond to gender-based violence. PEPFAR's leadership on the issue of gender-based violence in particular and the recognition of its connection to global health also furthers our recently released 2022 U.S. strategy to prevent and respond to gender-based violence globally, which was just launched this past Monday by Secretary Blinken, Administrator Power, and Gender Policy Council Director Klein. Since its first iteration in 2012, our global strategy on gender-based violence has been critical in elevating the human rights of women and girls as a U.S. national security, diplomatic, and foreign assistance priority. The updated strategy we've just released, which was informed by extensive consultation with more than 450 survivors, technical experts, implementers, and advocates, builds on lessons learned and draws from new insight, rigorous evidence, and importantly, the leadership and the experiences of survivors, particularly those from underrepresented communities and populations that are most impacted by violence and abuse. With our new strategy to combat gender-based violence globally, the administration is taking decisive action to further our commitment to prevent and respond to this issue through programming, policy, and diplomatic efforts, including, of course, indispensable programs like PEPFAR. And we've also made updates to the strategy to address 21st century threats, such as online harassment and abuse, the ways in which climate change exacerbates the risks of gender-based violence, and the proliferation of conflict-related sexual violence around the world. Following this week's launch, the Department of State and USAID will be tasked with reviewing and updating agency-specific implementation plans to include metrics of progress. The strategy also commits the United States to an interagency results framework, an annual progress review, and consultations with civil society to adapt and improve implementation, a process in which I hope many of you will take part, particularly as PEPFAR continues to help lead much of this important work. I'm so grateful for the opportunity to share the administration's priorities on gender equity and equality, to which the PEPFAR program is, of course, so critical, and to be in partnership with all of you in advancing equity in our global health work. Thank you very much. Back to you, Gerard.
Thanks so much, Rachel. Really appreciate your support and partnership over the years. You've given us a lot to think about and a lot of tools as well at our disposal to implement today and tomorrow. And so there's no time to wait. Thank you for also raising the important issue of gender-based violence in South Africa. Just this past week, South Africa's President Ramaphosa has said gender-based violence is the new pandemic in South Africa, and we know that is an issue that is affecting a lot of countries in the region. So thanks for that. So colleagues, if you didn't know, now you know. Equity is a major policy priority for the United States, and I want to just thank my colleagues in the U.S. government for showing up every single day, and literally today as well, for being with us. We're now going to switch gears now to our last and final set of speakers in our panel on knowing gaps and closing gaps. I've had a few questions about schedule, and I want to assure everybody that we're not going to cut the workshop times by any means. We're going to look to make up for the time at the end of the plenary, and as Special Envoy Stern said, we're here to take up space. And so I can assure you that we're not going to sacrifice any of the time that we've allotted for our speakers or for our workshop sessions, so long as colleagues can be flexible at the end for the closing plenary. So our third panel, we'll dive deeper into the inequalities that are persistent in the HIV response. More specifically, we have 4 global leaders that are in the trenches of this fight. We've got an epidemiologist, a human rights lawyer, a mother, a businesswoman, and an advocate, and finally a youth leader with us who's got an immense following in the global HIV community. I want to first turn over to Dr. Steph Baral, who is professor in the Department of Epidemiology at Johns Hopkins. Steph will share examples of what leveraging equity in the HIV response should be. And I know we have some slides queued up for you, Steph, and I'll turn it over to you, sir.
Great. Thank you very much. So it'd be great if we could start the slide set. So indeed, I am going to try to talk about a lot in just very little, because I realize we're running late and the workshops are really critical to this discussion. Next slide, please. But indeed, I'm going to talk about a number of examples that are data-driven in terms of some of these issues around equity, structural determinants, and HIV risks. I'm going to give examples of work and recent data that have been collected about stigma as a barrier to ART use among particularly young people. We'll talk about the relationships between criminalization and HIV among gay men and other men who have sex with men, building on the example that Ambassador Nkengasong gave earlier about the prevention impacts of treatment, particularly among sex workers in East Swatini, talk a little bit about transgender people and some key themes. So next slide, please. And I'm really sorry about how fast I'll be talking. I'll just say that I think heterogeneity, this idea that there's a distribution of risks, is a fundamental principle of infectious diseases, that 2 people are not at the same risk. And I think responding to that in any place of the world is sort of central to effectively responding to HIV. And that, equity, as we think about it, is the importance of it is that we address the conditions that mechanistically create those disproportionate risks. And so not just at the individual level, but really those social and structural barriers that are driving disparities at the individual level in terms of health outcomes. And that if we don't do that, well-meaning interventions can actually concentrate epidemics, which we may have seen historically. Next slide, please. So to sort of, to visualize that, and I think we've already heard this so nicely from Peter Sands and from Dr. Nkengasong and others, individual level determinants are really contextualized by social and sexual networks, community level determinants, including stigma, public policy, including criminalization. And so I'll try to present some data that we increasingly understand those to be truly central to doing better in terms of HIV outcomes and achieving these goals that we have just in 7 years' time. Next slide, please. So to start with, I'm going to give examples from data that have just been collected in the last year, led by GNP Plus under the PL-HIV Stigma Index 2.0, including the international community of women living with HIV and UNAIDS. These are data that are by and for people living with HIV, and data analyses are also led by local data analysis priorities are also locally led. The data I'll be presenting today are from cisgender women that are known their status for greater than 12 months. There's more than 10,000 people in this sample, and importantly, data collected just in the last year. So very recent understanding. Next slide, please. And I think I just want to sort of make a few points here because I think we've heard about this. So this is looking at the relationship between current treatment use, ART use, and violence. And what we see is that for women who've experienced sexual violence, they are 70% less likely to be using treatment. And, you know, while I don't have time to talk about all of it, folks who have experienced nearly 10% of the sample of these 11,000 folks have experienced blackmail, and they were almost a third, or I should say more than a third less likely to be using treatment. So as we think about our treatment programs, we think about these as fundamental barriers that if we can't overcome sexual violence and blackmail and other determinants that continue to affect people living with HIV, you know, we continue to see limitations in treatment. And I'll note that we work using data from the HIV Policy Lab. We saw if there were differences between whether there were stated violence protections at place at the country level, and we didn't see differences. And I think it speaks to the importance of policy implementation and also understanding people's individual experiences as barriers to treatment at the clinic and community level. Next slide, please. Thinking also about how this affects youth, because youth are central to our future as a people and also to the HIV response, we actually saw higher burdens of verbal abuse and physical abuse. So, you know, women aged 18 to 24 were nearly 2 times more likely to experience physical abuse by a healthcare provider as compared to older people living with HIV. So when we think about this need to do better for youth and with youth living with HIV, you know, we see this as a fundamental barrier, even in with recent data. Next slide. And I think this really aligns closely with what's happening at a global level. We see, and as Ambassador Nkengasong said, we see lower treatment uptake among youth. We see lower levels of viral load suppression among youth. And it really begs the question of how we can overcome this to achieve these goals of no new infections in just 7 years' time. Next slide, please. So moving on to thinking about criminalization and the relationships that exist between that and HIV status. And so these are data that have been collected over a long period of time with more than 8,000 participants and 23 study sites. Next slide. And I'll just say that here we use the ILGA classification of criminalization status. And so either folks who were not criminalized, there was a criminalization of up to 8 years imprisonment, or what was considered by ILGA severely criminalized, which is greater than 10 years to life in prison based on sexual orientation or sexual practices. Next slide. And what I'll say here is that, you know, after we adjusted, just as a key point, and there's a lot more information available, but after you adjusted for a lot of these individual level determinants, gay men and other MSM who lived in criminalized settings were more than 2.5 times more likely to be living with HIV. And in severe criminalizations, they were more than 5 times likely to be living with HIV. These are adjusted analyses after adjusting for a whole series of individual determinants. Next slide. We also consider testing as central to both PrEP for folks who are not at risk for HIV, and as well, obviously, treatment for those living with HIV. What we saw is that gay men who live in criminalized settings were, 12% less likely to have ever tested for HIV, and in severe criminalized settings, nearly 40% less likely. And so again, it just speaks to this fundamental intervention like testing and what the effects of criminalization are on it. Next slide, please. I think we've also heard a lot about this importance of treatment as treatment. Treatment is the fundamental intervention, I think, that exists in the context of HIV. It is rights affirming, it is life saving, but it's also important to think about the separation of treatment as treatment for people living with HIV and sort of, optimizing these prevention benefits. And what I'll just say is that as we take a longer term view, we are 40 years into HIV, as we take a longer term view, we see that actually addressing the needs of smaller communities that have larger sexual networks and larger risks of onward transmission is really central to sort of optimizing the prevention impact of treatment, not the life-saving treatment impact of it. And that when we look at that, it really speaks to the importance of addressing the needs of these smaller communities, even in very generalized epidemics. And I'll give an example on the next slide. So I'll say that, Ambassador Nkengasong gave updated data from Eswatini where things are looking better. These are 2020 data. But what we looked at here is what would we achieve if we achieved equity in outcomes? So if we achieved the 90-90-90 among sex workers, similar to the 99-90 that had been achieved overall. And what we see is that as you take a longer term view over the 10 years, that when you do better in terms of not leaving particular communities with large sexual networks and large risks of onward transmission behind, we do better across the population, even in generalized epidemics. So we need to have a longer term view of assessing these benefits, but nonetheless, they are absolutely there. Next slide, please. Then I'll just finish by saying a very recent review led by Aidan Scheim and Sari Reiser and others is to say that, for trans populations, we still know very little. There are data from about 5 countries across sub-Saharan Africa where they've been done. They've shown incredibly disproportionate risks of HIV, but we still continue to know very little, and just speaks to the importance of doing better, of really stratifying gender identity in these studies moving forward. Next slide, please. So in these last minute of my time, I just want to say that universal treatment for HIV is obviously a human rights affirming and life-saving intervention, but we really optimize the prevention impacts of it when we achieve equitable impacts amongst those who have a lot of onward transmission risks. I think all the data that I've ever been part of and that I've ever seen is that that the world is far more similar than it is different. We don't know that there's any differences in terms of diversity of sexual orientations and gender identities across regions, even if they're often assumed to be regional differences. And I think when we think about optimizing equity, it means overcoming these sort of preconceived notions of the epidemiology of HIV, ensuring that it's data-driven in our decisions, and that depending on who is left behind, who is in that 10-19-27, you can really sustain generalized epidemics. And so with that, I want to thank a lot of folks, particularly some of the logos are included here, and the opportunity to present today. Thank you very much.
Thanks. Thank you so much, Steph. I hope you have a glass of water near you because you've given us a lot to think about and digest in just a short amount of time. I appreciate you calling in from Senegal and for making time to be with us today. We're gonna move quickly to our next speaker. Dr. Alan Maleshe is here, and Alan will talk about why the law matters in the global HIV response. Alan's an advocate of the High Court of Kenya and a human rights defender for over 15 years, with experience working on ethics, governance, policy, and rights, including managing the rights-based responses for affected, marginalized, and vulnerable populations. He is currently serving as a human rights scholar at Georgetown University Law Center here in Washington. We're so lucky to have him down the street. Alan, welcome to you, and thank you very much for being with us.
Thank you for having me, and I will try to follow the pace that has been set on saving time. Let me start with good news from Kenya. This morning at about 2 a.m. on this time, the High Court of Kenya issued its first decision on the issue concerning forced and coerced sterilization of women living with HIV. And the High Court ruled that subjecting women who are living with HIV to tubal ligation without their informed consent amounts to a violation of their right to health, their right to dignity, their right to be free from discrimination, and most importantly, their right to form a family. The court proceeded to award damages of about 3 million Kenya shillings, among other remedies that were given. This is a landmark case, which the organization I work for, Kelin, was involved in, and I was also the advocate of the women. So what we're speaking about is true reality, because this decision can then shape the consent. I'd be tempted to speak about it, but I plan to speak about a different decision in order to bring the practicality of what we're talking about, and for PEPFAR colleagues and other partners on the call to see and appreciate that these things actually can be done and can happen. I know many of you have been in the HIV response, and the word global or all-in campaign may ring a bell. Well, it did ring a bell in Kenya in 2015 when we had a presidential directive that sought to collect the names of children who are living with HIV, their guardians, pregnant women, with a view of trying to ensure, which we normally do, that no one is left behind and everyone gets onto treatment. And so that directive was challenged in court again by Kelin on the fact that it violated the right to privacy. And when that was challenged successfully, the court agreed that indeed, by going about the manner in which the president issued the directive to collect data, whether his intentions were good or not, then it would have violated the right to privacy and the best interest of the child. And so it is important for us to appreciate that even though the case was won and eventually privacy guidelines were developed and there was a Data Protection Act, I think the importance of understanding why the law matters is to understand what investments are then made. We were lucky to have a HIV Act in Kenya that is very progressive, and we have a more progressive one that applies to all East African countries called the EAC Act. We were then able to rely on that act because investments had been made to train lawyers on how to litigate. Investments had been made to train communities to understand what's a human rights violation, how can they be able to have redress. Investments had been made to train judges to know what are HIV issues, what does it mean when they come before your court, how do you deal with issues. Investments had been made in terms of the media being able to report responsibly and ensure issues are being brought forth. So I want us to appreciate that even though you see the successes of judgments, they don't happen overnight. There are investments that need to happen, and PEPFAR and partners are well placed to make these investments in countries. Now, Ambassador John spoke about where are best practices, where is the evidence? The evidence exists in terms of what needs to happen. We've got a number of baselines done by the Global Fund that tell us what activities need to be funded. We've got numerous legal environmental assessments that have been done by UNDP. We have at the O'Neill Institute, the HIV Policy Lab, that has a number of information that can help people see why it's important to have a legal environment. So all those aspects are there. What is missing is for us to connect these gaps to actual implementation on the ground. And I want you to think about, I know Jennifer Stan said that there's not much money, but imagine if you could train all the judicial officers in Kenya, who are about 4,000, with a budget of about $500,000 over a period of 2 years, you'd have a deliverable that says all the judicial officers have been sensitized on HIV and human rights issues. And should these things come before the court, because we don't know when they'll come before the court, you're sort of guaranteed that this will be addressed. And you could do the same for parliamentarians. You could do the same for prison wardens. You could do the same for the media. You could do the same for many other players. And such small interventions help you get to your 95 because you're trying to address what are the things making it not possible for a gay man to get their medicine? What is it making us possible not to reach trans people? What is it that is making it difficult for us to give effective intervention to sex workers? And it requires some of this incremental change, and it varies in different country contexts. So as I conclude, because I really want to ensure we keep time, I think we need to move from the theory in our boardrooms, in our legal environmental assessments, and direct funding to where it needs to be. You need to put money and resources in the hands of communities. You need to support civil society who are challenging some of these laws and policies. You need to work closely with parliamentarians to ensure they don't pass laws that are problematic. And when they do, you may have worked with the judges to ensure when the law is challenged, they know exactly how to make a reasonable decision. So there are various interventions that could be done. And I do hope that this conversation and the investments PEPFAR has made as PEPFAR, the investments the US government has made in Global Fund are quite significant to be able to take forward. So let's reflect from that practical perspective and realize if we direct our resources to just a few key programs, you can actually make certain breakthroughs to reach the most marginalized and those who are left behind. So let's reflect on it and let's continue to discuss. Back to you.
Alan, it's always so inspiring to hear you speak from theory to practice to real change on the ground. Thank you for being a trailblazer on behalf of so many and for being a leader in our community. We had one slide for you. I don't know if you wanted to touch on it. You already did.
I had forgotten my slides. I only had one slide, and it's self-explanatory. It's where I draw my inspiration. There was a great commission called the Global Commission on HIV and the Law. And I just want to leave you with that quote. I won't read through it, but basically what it's saying, if you have good laws and they're enforced, then you're likely to have better outcomes in terms of addressing the issues of HIV. And for the finance people in the house, save money, because the economists will tell you what's the value add of the intervention. So I'll just leave you with that quote that I had forgotten. Thanks for reminding me, but it's available in the Global Commission report. Back to you.
Thank you, Alan. We're going to switch gears now, colleagues, to another equity issue that we've heard a little bit about already. Each week, 4,900 adolescent girls and young women between the ages of 15 to 24 become infected with HIV, and that number will give us all, and we should give that person a pause too. Thank you. So we're going to hear from Maureen Marenga, who's the founder and executive director of the Lean On Me Foundation in Kenya. Through her lived experience, Maureen has seen the inequalities and vulnerabilities young women and adolescent girls living with HIV experience day in and day out. Maureen, thank you for making some time to be with us today. The floor is yours.
Thank you so much, Jira, and thank you everyone who is around. The presentations have been really inspiring, and I really thank the organizers of this forum, because this is the right direction to take. After the report on inequity from UNAIDS, I think it was really thoughtful of PEPFAR to have this forum, because it's sometimes really good to hit when the road is still hot. So I must appreciate all actors who are in the HIV response. We have made tremendous gains in this response. We also have, like Peter San said, the tool to make a great difference. In the late 90s, when I was diagnosed with HIV, and in early 2000, we did not have preventive tools. We could not save our children from HIV. Our children got infected. Our kids could not be diagnosed. So you had your baby and you are told we don't have diagnosis for children, and therefore you have to wait for 9 months until we are able to use the adult diagnosis on them. And so many children lost their lives in this process of waiting. And so for those of us whose children survived and we diagnosed them, there was no treatment. So, I mean, we were living in a world where HIV became a death sentence, and it made mothers very guilty that you had passed a death sentence to your child. So when there was no treatment for them, some of us had to use adult treatment on our children, which was not a very good thing and very comfortable place to be. And like Alan just said, apart from that, we were coerced to sterilization. Women were being told that if you get pregnant and have babies, you're going to infect them, and it is not good to infect little children. So we want to do tubal ligation on you so that you are not becoming a weapon of mass destruction. And so women were made to feel very guilty about being mothers. Fast forward, in 2013, I did not go through the process because someone told me it was a painful process, and my family were kind of discouraging me. And so I was still making time. We did not know that that was a violation of our rights. But later, through Kelly and thanks to Alan and taking the case to court, we were able to realize that this was actually a violation of our rights. So in 2013, I had another baby. The situation was different then. I was on antiretroviral therapy. I had access to viral load monitoring. I received prophylaxis for my child. He was able to be diagnosed early on in his life, and he is HIV-free. So it is actually doable. We have the tools to have a HIV-free baby, and every mother deserves to feel less guilty. With the tools we have, we can ensure that every mother, regardless of which part of the world they come from, are able to achieve viral suppression and prevent HIV from their children. But why are we not there? We have medicalized pediatric HIV. We have created iniquities that do not allow women to seek services and be able to really enjoy motherhood. Most of us have reduced prevention of mother-to-child transmission into having ARVs in the health facilities in the assumption that women will take those and adhere to them. But we are not taking into consideration the challenges that women have in terms of access, adherence, and retention to services. And they are varied, ranging from stigma, gender-based violence, economic inequities, and the list is endless. Medicalizing HIV and giving women antiretroviral therapy has not brought us to where we are. If you read the UNAIDS report, we have so many children still getting infected. In Kenya right now, we are dealing with the triple threat, where we have increased HIV infection among young women and girls. We have increased rates of gender-based violence among adolescent girls and young women, as well as increased HIV infection. So if these young women are getting HIV infected, they're living in unsafe places, and they're pregnant, it means we are looking at another huge population or another huge epidemic of children infected with HIV. We need to, like a previous speaker said, we need to move from the health facilities and address the iniquities and address the root causes of the reason people are not accessing these services. For example, in our clinics, when young women and other women attend for the antenatal clinics, before they're given services, they're asked to bring their sexual partners if they're HIV-free. So if the sexual partners do not comply, then it means these women miss the services, and the multiple effect is that the children also miss an opportunity to stay HIV-free. Why don't we focus on supporting the woman and the child before we think of the partners? We also want better diagnostics and a variety of treatment for our children, but we are cognizant to the fact that what we have now is adequate to get the job done. Data on pediatric and children is also not available, and where it is not very clear. So we need to work on data. For example, WHO collects data of 0 to 15 years old. I think this is too ambiguous if we want to save pediatrics who are 0 to 5 years old or children below 14 years old. So I think we need to disaggregate the data even further to be able to identify the challenges and the iniquities and be able to reach the children more. We need to invest on child-focused community networks. Post-COVID saw the need to find children that the system missed as a result of stockouts and COVID restriction. We decided to map out some of our people living with HIV networks to see who had resources to help us go to the community and find the missing children. And in Kenya, none of them had it, like zero. Nobody had money to reach out to children in the community. All the money was in the health facility for PMTCT. This is unacceptable in this era and time when we know that the iniquities have really created huge barriers for people to go to health facilities. So we need to change this if we want to be very, very deliberate and true to our call of ensuring that children have HIV-free start to life and they stay HIV-free. Thank you very much. Back to you, Jairo.
Thank you so much, Maureen. Thank you for sharing your firsthand story, as well as bringing the spotlight to children as a key priority population to close equity gaps. I want to also apologize. We misspelled your name on the slide here. I promise I'll make it up to you. So sorry about that. So much leadership coming out of Kenya, and we appreciate the work that you and Alan and others do every single day. So thank you again. We're going to hear from our last speaker in this opening plenary, and that is Tinashe Rufuruwadzu. Tinashe is a director of programs for the Global Network of Young People Living with HIV. They are leading a movement for rights of young people to live healthy and fulfilling lives. Tinashe reminds us that young people are experts and leaders in the HIV response, and we should be listening to them. So let's cue up the video from Tinashe, please.
Thank you, Ambassador Nkenkeson and team, for the invitation to represent the perspective of young people in this important discussion. We applaud PEPFAR for being intentional about the meaningful engagement of young people in all our diversity, for inviting us to lay out our priorities in the listening sessions, and for the opportunity to contribute to the development of your new strategy. As young activists, we recognize the tremendous difference PEPFAR's support has meant for our generation. As other speakers have highlighted, we have a long way to go to achieve our target of ending the global AIDS epidemic as a public health threat by 2030. The latest UNAIDS report says inequalities are stopping the world from ending AIDS. Persistent gender inequalities mean that adolescent girls and young women in sub-Saharan Africa are 3 times more likely to acquire HIV than their male counterparts. Widespread stigma, discrimination, and criminalization against key populations make young people scared to seek health services and access new and more effective tools to prevent HIV. So, how can we work towards closing these gaps? Your new strategy, Fulfilling America's Promise to End the HIV and AIDS Pandemic by 2030, rightly prioritizes health equity for priority populations, which includes young people. Focus Area 2 of your strategy talks about how you will meaningfully partner with youth-led organizations and networks. The good news is that the youth movement has tips and guidelines to help you do this. Y+ Global has developed guidelines called We Matter, Value Us to guide partners on how to engage young people ethically and meaningfully. Young people are structured in youth networks, including those led by young women and young key populations. We are organized and we are leading the response around the world. We need more resources and meaningful partnerships to sustain our networks and help us influence policies and deliver programs. Your strategy also highlights the need for accessible, destigmatizing, and empowering HIV and AIDS content and innovative youth-friendly service delivery. We know how to reach and support our peers and can help you design programs. We also need and policies that provides comprehensive sexuality education and allows young people to access HIV testing and sexual and reproductive services without parental consent. We also know that more needs to be done to close the digital divide and address the risks that young women and young key populations face. I urge PEPFAR to continue collaborating with young people as leaders and not just as beneficiaries. Together, we will advance health equity for all populations, especially adolescents and young people in all our diversity. Thank you.
Super. Thank you to Tinashe, to Alan, to Steph, and to Maureen for that very enlightening session. This concludes our formal set of speeches for the opening plenary. Yes, we're still at the opening plenary. I know it's been close to 2 hours, but as we said throughout the time together, that we're not going to sacrifice or cut any of the time that we have for the workshops. We'll now be transitioning to the workshop hour. We'll still keep it for 60 minutes. While we're in workshops, I'll work with our speakers for the closing plenary to see if we can shorten that period, but we're still going to expect to go perhaps 15, 20 minutes past 12 noon Eastern Standard Time. So just wanted to share that so we can plan accordingly. We have 3 concurrent workshops happening now, as you could see here from the screen. One on key population service delivery, one on advancing rights for adolescent girls and young women, and one on leading the global movement to end AIDS in children. Good afternoon, everybody. We are back here just getting sorted with our rapporteur slides. So just give us a couple minutes here. Let me ask Mark, if you're able to, can I take a peek at the next slide and see if this is the key themes? No, it's not. Okay. Let's, would it be possible to bring up that slide from Sharif's deck?
Mark, I updated it. It's on SharePoint now. It's there.
And then that'll give Sharif a couple more minutes to get the slides from the rapporteurs, and we can dive right in.
Okay, sorry, which slide are you looking for?
It says, what does health equity, this is it, perfect, yep. All right, so
thanks.
This is perfect, thank you, Mark. All right, everybody, welcome back. This is the closing plenary of our equity workshop. We started the day with some highlights in terms of the commonality of equity across program priorities for PEPFAR, for UNAIDS, for Global Fund. We showed you how equity is a major policy priority for the United States, and we also heard about major gaps across priority populations. Now we're going to hear from you and from the rapporteurs of the respective sessions. I'm personally looking forward to hearing the recommendations and themes. I know the ambassador is as well. But before I turn it over and to borrow a couple minutes as those slides come together, we wanted to project the themes that we pulled out from the question that we asked each of you at the registration, which was, what does health equity mean to you? And we got over 400 responses, and these were the thematic areas that resonated in terms of the number of responses. You can see some of these themes have come up throughout the day already: fairness, diversity and inclusion, access, structural barriers. I love Ubuntu is here, equalize, intersectionality, stigma, human rights, health for all. This is what you told us health equity means to you, and I'm very much looking forward to hearing the reports from each of the sessions. Ambassador, I see you on. Welcome, sir. Thank you. Let me ask my colleagues if we have the first slide for the rapporteur. Are we ready to go?
Yes.
Okay.
Yes, just one more slide.
Okay. If we could start with whatever slide is available, I think that would be great. And then we could come back to the others as needed. I'm just trying to keep us on track to end by 12:30.
I don't know if we have a slide. Maybe I can just run through quickly.
Hello, Janet. Welcome.
Hello.
Yeah, Janet, why don't you go ahead, Janet? Is this yours? No, this, let's see.
No, that's yours. I don't know that we have a slide, so let me just run through a couple of key points that came out of a very rich session, okay?
Sounds good.
One of the big themes that came out was the importance of investments in AGYW-led organizations. And this was both the issue of course, resources, but also importantly, thought leadership and how to better engage with, work with AGYW in the design and the implementation and the monitoring of these programs. And could we be more creative thinking about internships for AGYW at PEPFAR, the creation of AGYW councils for countries, different ways to really ensure that those voices and that leadership is integrated into the way PEPFAR is designing its program, and that we are clear that the resources need to be directed toward AGYW-led organizations. Another issue that came up was to see AGYW in all their diversity. And this includes pregnant AGYW, it includes AGYW with disabilities, it includes the broader range of situations that adolescent girls and young women find themselves in, so that we are making sure that we are reaching the communities that are at risk and whose voices we need to be including in the programming and the policies. A lot of discussion around SRHR and how to better integrate SRHR into what PEPFAR is doing, how to look at positive SRHR for AGYW, how to look at ensuring that the regulations and the policies at the country level that affect SRHR access are part of what PEPFAR is looking at the country level. Number 3 is looking at DREAMS, keeping DREAMS as a very comprehensive program to ensure that its ability to address stigma and discrimination, to engage communities, and to continue to have the sort of data coming out of the DREAMS countries that PEPFAR has required. And there are some concerns that some of that might be weakened, and the underscoring the importance of, to keep it as a comprehensive program, we need the data to be underpinning the impact of the programs on the ground. Another area that came up was increasing PEPFAR's role in health diplomacy around AGYW, to look at some of the specific issues that impact AGYW on the ground, and how can the State Department do more targeted work on looking at the structural barriers that drive inequities, age of consent laws, comprehensive sexuality education's restrictions on SRHR, and different ways that health diplomacy can actually be another dimension of what PEPFAR is doing. And was that 5 already? Was someone taking notes? That's 1, 2, 3, 4. I think that might have been 5, but I want to just add the other point that came in very clearly, that's part and parcel of all of this, is engaging communities more broadly. So that is not only, of course, AGYW, it's also men and boys, it's also faith-based organizations and community leaders, because to address these issues of access and stigma and discrimination, and very importantly, what came up, the question of choice in prevention technologies, we're going to need communities to all be engaged to ensure that that access is expanded in the way that suits the needs of adolescent girls in all their diversity. So I think that wraps up a very rich discussion, and I hope that we can continue to be working on these issues and really operationalize some of these ideas. So thank you.
Brilliant, Janet. Thank you so much for the succinct summary there. I want to also thank Janet and Ashnil, as well as the selected discussants for their interventions during the session. Thanks for that summary. And just to reiterate, as we're getting ready for the next readout, what we're hearing is a top line summary of the key themes that emerge from the sessions. Our technical leads and our teams are working to capture the chat and the more detailed notes that will feed into the work that we're doing. And if folks want to put comments into the chat, we encourage you to do so as well. So let's transition now to our second report. Who is coming in for key populations, or are we doing children?
This is Erin. I can jump in for key populations. Our slide is still coming together a little bit, so we're committed to putting that together, but maybe just in the interest of time. First, I'd also like to say thank you. We took a team approach to rapporteuring, so thank you to Humphrey and Dondu from Zimbabwe, as well as Stella Alamo from Uganda. They're both having some connectivity challenges. So they were able to send us some notes, but just to deal with the connectivity issues, I will just go ahead and share that. And just to say, we had an extremely rich set of comments and interventions, as well as in the chat. And I think we really haven't quite synthesized all of that. But just to pick up on some of the key notes that our rapporteurs were able to share. So one was about elevating the importance of equity via data and evidence-driven approaches. And this was in particular a call for developing metrics to measure health inequities, and really helping kind of to unpack the 10-10-10 societal enabler targets, as well as the 30-60-80 community-led response targets and efforts to really, help drive some of the responses on addressing societal and structural barriers. We just heard resounding, moving to the next kind of key theme or recommendation, just a really resounding push and need to ensure meaningful engagement, leadership, and partnership with communities. This is both in terms, or this is covers a range of aspects, including the capturing of data, including the design of programs, including as we think about sustainability, including as we think about the networks and the relationships that are needed at the global, regional, and national levels to roll out some of the key new interventions and technologies, and really that having that community leadership, partnership, and engagement is really key to how we're delivering the services, but also tackling the structural barriers. A third kind of theme was on global financing and policy, including looking within our own PEPFAR structure and some of those kind of how we structure ourselves, our grant making, how we allocate funds, both kind of at the project level, but also there was a very specific recommendation on having budget controls in the same way that we did for PrEP, and really showing that led to a considerable more investment, doing something similar along those lines for key populations programming, including for structural interventions. An additional theme was around not just the metrics of 10-10-10, but hearing about how to the need to document, first of all, document human rights violations, but then really support communities in their redress, in making change, and really tackling those. And that's about different partnerships with different organizations, different spheres and sectors. We heard an example about how an LEA, a legal environment assessment, was done, and then really the need to stimulate action going further. Again, also an ask, for increased partnerships and working with law enforcement organizations to sensitize them and build partnerships with them in terms of working on key population service. So I think I'll stop there. There was quite a bit more, as I mentioned. We're still synthesizing a little bit, and want to thank our discussants, participants, and the rapporteurs for this session. Thank you so much.
Thank you so much, Erin. Well done. We saw some of the slides from your session, but we'll do a more comprehensive summary and send these out collectively to folks. Thank you to you. Thank you to Bill Paul for co-moderating, and to our colleagues for their participation in that session. Let's go to our last report out from the group for workshop 3 on leading the global movement to end AIDS in children. And I see that this group is very well organized with their slide. And we're going to turn it over to, is it Dr. Eleanor? Is she available to come in?
Thank you very much. We also took a team approach to rapporteuring with Michelle Zavila. And our first recommendation is on better treatment options for women living with HIV, the mothers living with HIV, pregnant and lactating, and also simpler treatment options for children. And in addition to this recommendation, ensuring that we have early HIV literacy programs for both the mothers, the caregivers, as we give them the better treatment options. Our second recommendation is innovative HIV and new TB case identification strategies with testers and community resource persons specifically tagged to supporting children living with HIV. We know that there are lay testers, there are community resource persons, but the recommendation here is that we should have those that are specifically tagged to supporting our children and their mothers. The third recommendation is what has been coming out from the previous groups, community engagement, including faith-based organizations, using family-centered approaches with well-designed psychosocial and socio-economic interventions to address structural barriers. We all heard that giving treatment alone is not enough, and the fact that we need to address the bottlenecks that are causing the mothers to fall out of treatment, the children not to be retained in care, and interventions such as peer-to-peer support, HIV-sensitive social protection, and working with social welfare ministries and social service workforce. So looking at a multi-sectoral approach that goes beyond the health sector to address the structural barriers that we've all had throughout this workshop. The fourth recommendation is improved access to laboratory diagnostics. We had an example of Kenya, where for weeks people were not being tested because of lack of testing kits, and also having integrated data systems, including promoting disaggregated and individual level patient data. So when we talk about integrating, we are talking about integrating the clinical, laboratory, and community systems, data systems, to ensure that there's a linkage across these three areas, and also utilizing digital technologies to make it easy for the community support systems of health workers to quickly relay information to the health facility data systems for an efficient management of our patients. And the last recommendation is an integrated approach to implementing HIV programs, moving away from implementing silo programs. For instance, we can integrate HIV testing into the immunization programs, and also ensuring that there's increased and dedicated funding specifically for pediatric and adolescent HIV programs and for mothers who are pregnant and lactating. Thank you very much, and over to you, Chair.
Thank you so much, Dr. Eleanor. Really appreciate the details that you and the group have provided, which will be very helpful for PEPFAR and our colleagues. Thank you to Hillary Wolf and Gretchen Bachman as well for facilitating the session, as well as our discussants and participants that made that session possible. So thanks to all of you for that report. I'm happy to share that we are, for the first time today, 1 minute ahead of schedule. And how we're gonna keep this going. And as we digest what we've learned and what this all means for PEPFAR and implementing partners moving forward, we have a special treat to be joined by Assistant Secretary Lois Pace. And I'm going to ask while Lois is speaking for our interagency deputy principals to also come together afterwards and share their reflections on what's being heard. But before we do that, let me just say that Lois is someone who needs no introduction to this room or to this community, but we're going to give her one anyway. She is a U.S. government leader on setting important priorities and policies that promote public health and global health interests worldwide. Lois has been a champion of equity in the halls of Congress, in the halls of the UN, even before it was fashionable to do so. And previously, she served as the president and executive director of the Global Health Council and was a member of the Biden-Harris transition team and the COVID-19 advisory board for President Biden. So it gives me much pleasure and a little bit of some goosebumps to welcome Lois Pace to our workshop. Lois, floor is yours.
Dr. Adivosian, you are way too kind. Thank you very much for that really gracious introduction. And I know I'm coming at the end of a robust series of discussions or conversations. I was able to listen in and get a sense of you all's takeaways. And, you know, I would expect nothing less than what I heard from this group assembled to really help us move forward with this bright, bold vision that Ambassador Nkengasong has mapped out for us, starting with equity at the core. And I do want to thank not just you, Gerard, but also Mr. Ambassador, who I believe is on with us, as well as his team, including Dr. Achudakar, whom I'll miss deeply as she transitions into her own fabulous leadership opportunity following her service with us here. But with that, I will just say a few things, knowing that there are many people to still come after me, and knowing that you all are probably ready to round things out. Again, I do want to start with folks here and just say how grateful I am that you all and the people with you and behind you are really sort of making it even more clear to the world at large what we mean to say, but also what we mean to do when we talk about equity at the center. I know for us here, where I sit in the Department of Health, it's something that we talk about often. We try not to just talk about it, but also be about it. And that is from research to service to everything in between, including the really important innovations that come out of our shop. In many ways, it's, I think, as we all have said, and frankly know, it's not just who we serve or who is reached, and how we can make their lives more equitable, but it's about the process, right? It's about the ways that we approach the work that we do, the ways that we try to advance these outcomes. I mean, it's even the nitty gritty in terms of where and how we deliver services or approve contracts, or frankly, who we bring to the table, like today, to even help us map out these important ideas and roadmaps into the future. So that's our take on this word, on this term. And Gerard, I appreciated you sort of kicking us off by reminding people like what equity has meant to each of us, even just coming to the table today. It's meant a lot of things, frankly. And I think it's our goal and our role to really help bring all of our various perspectives together so that it can mean all those things collectively, and that even with the diversity of equity itself and the equity agenda, that we can still move forward together and realize this collective impact. Something else I wanted to share before I pass the mic back to you, Gerard, is I actually was a part of a conversation recently about equity, and it was interesting and it was important because someone said to me, and I think he meant well, to say, look, you have to be careful with this equity agenda because it's really coming across as more of a headline or more of a tagline than something that really is going to make a difference. And he seemed to suggest that it was even off-putting to lead in this way. And of course, I have a different view there, and I think the other leaders here have a different view, and that's not just personal, but it's a policy position we have to say that this is important, that this is fundamental. But that question or that conversation really helped me understand how important it is that we communicate to others outside this virtual room what it is we're trying to accomplish, because it does still feel new and abstract or somehow distant to them. And what I appreciate so much about this workshop is the responsibility we're each taking here, and that you all are taking to operationalize equity in a way that resonates with folks. That truly matters. And that obviously sort of came through in that dialogue that I had. But I also want to be careful with us thinking that, or accepting that we need to be somehow apologetic in that work, right? And sort of bear the burden of convincing everyone at risk of not doing this work as fervently as it needs to be done. So what do I mean by that? I mean, not pulling back on what we name and who we name in this process. And, it has been really important, I know, and I've heard, for you all to hear from us that we are talking about gender-based violence, we're talking about stigma and discrimination, we're talking about harmful policies and practices, and saying it out loud matter, talking about who is included in this work as well, just as you all have done in these report outs, is also critical, right? We're talking about LGBTQI+ communities, people who use drugs, sex workers, racial and ethnic minorities, women and girls, but we have to also even at the risk of making others uncomfortable or confusing them with our mission, or, you know, by challenging the status quo, that is us saying how central this truly is to our work and to our progress, right? And so, you know, with that, again, I want to come back to where I started with how, and with where you started, which is to reiterate that this isn't just a vision, right? This isn't just a dream that our leadership has, and that, you know, that people have identified. This can be done, and it must be done, and you all are paving the way for us to get it done. So thank you again for all that you have done to help inform this work, to help reset this work, and to, particularly as we look at 20 years of PEPFAR going into 2023, how we ensure that we truly are reaching everyone wherever they are together. Thanks again.
Lois, thanks so much for your partnership and for your support of PEPFAR and global health issues over so many years. Thanks for, I love what you said about operationalizing equity, and that is a perfect segue to our final set of reflections before we round out today. We started the morning 3.5 hours ago at this point by asking ourselves about what equity means, and we said that placing health equity at the center of the global public health response requires adaptive leadership, and we talked about what that leadership looks like. And now we're going to hear from 4 of our tremendous stewards of PEPFAR's implementing agencies, and hear from them about what today's session has meant, what the report outs from the workshops have meant, and what they will take back to their agencies and to their teams as we think about Lois's words, operationalizing equity. So in this order, I want to welcome Dr. Han Kang from USAID, Dr. Surbhi Modi from CDC, Dr. Kechi Achebe from Peace Corps, and Dr. Vienna Nightingale from the Department of Defense. Thank you again to the stewards of PEPFAR and the interagency. And let's go one by one. If I could ask you all just to reflect quickly, and then we'll turn over to our fearless leader, Ambassador Kang Azong, to close this out. So Dr. Kang, floor is yours.
Thank you, Dr. Retovasian, and good afternoon and good evening, and to my fellow Muslim participants, Assalamu alaikum and Jummah Mubarak. I had the privilege of being able to participate in the session on key populations and to be a part of this entire workshop, and I just wanted to thank all of the participants. You inspire us to drive progress beyond programs, to make sure that the I in USAID really does stand for inclusive and inclusion. Our agency, we are 100% committed to help our partner countries achieve the UNAIDS 10-10-10 targets and to remove health inequities through 3 approaches, and they're all grounded in the spirit of nothing about us without us. So the first approach is to ensure that we address the historical and contemporary injustices. We want to make sure that people are counted through focused surveys on key and priority populations. And we also want to promote the integration of HIV care into primary health, ensuring that people living with HIV have access to the full range of services that they need. The second approach is to overcome economic, social, and other obstacles. And the way that we're going to do this in USAID is to really leverage the expertise and the partnerships and the resources that we have from other parts of USAID. These are from colleagues who advance democracy, economic empowerment, education, and humanitarian assistance. And in fact, yesterday, USAID launched the Rainbow Fund to integrate LGBTQI+ considerations into existing or planned activities. And then the final approach is that we want to eliminate preventable health disparities. The way that we want to do this is to introduce prevention innovations. And of course, these are going to be based on acceptability studies that are involving communities to expand choice, and that will include long-acting cabotegravir and the dual prevention pill, among other methods. So back to you.
Thanks so much. Thank you so much, Han. Thanks for those thematic areas. Do we have Serbia on the line?
Yes, hi, thank you, Dr. Radovosian, and thanks so much, Ambassador Nkengasong, and to all of the stakeholders. This has been such an inspiring session, highlighting the remaining gaps. And I am so thankful that we've had this opportunity to come together and create an agenda for how we can improve our knowledge of those gaps and the strategies to close them. Reducing inequities is fundamental to CDC's global work, and we recognize that achieving health equity is a public health imperative. So we are so excited that the new PEPFAR strategy puts equity front and center, and we're fully aligned and excited to continue working with you to advance this agenda. Our agency has implemented a core strategy which aims to integrate health equity into the fabric of everything we do, from science and research to partnerships and workforce. And earlier this year, we published our strategy to advance global health equity, advancing our vision for a world in which everyone can achieve the highest level of health, regardless of social, economic, demographic, or geographic circumstance. And this session today, though, highlights that there's more that we should and can do. And so CDC will focus on 3 key areas to expand our efforts to close health equity gaps. First, we need to ensure we have the right data for action, the data that enable us to understand the gaps for each population and to measure the impact of our toolkit of interventions and monitor the progress towards closing those gaps, including the 10-10-10 priorities. A few activities that we'll build on here include continued support for the Violence Against Children surveys, developing innovative approaches to improve pediatric HIV estimates, and supporting high-quality key population surveys. Second, as we look to the future, we will continue to empower national partners and to partner with the communities that continue to face inequities in the response to HIV. We will continue to expand our approach to mentorship with more outreach to local partners and non-governmental organizations, including KP women and youth-led organizations, to support them fully leading and managing the response in the future. And finally, we'll continue to address stigma, discrimination, and other barriers that are slowing the progress in the HIV response, impeding access to services, and leaving us unprepared to address other health threats. We're doing that through our, as a co-convener of the Global Partnership for Action to Eliminate All Forms of HIV-related Stigma and Discrimination. And through that, we'll continue to support countries to identify and implement programmatic actions to measurably reduce stigma and discrimination. And we'll further partner with governments to support and expand training for healthcare workers on stigma, discrimination, human rights, medical ethics, and the response to gender-based violence. Thank you, and back over to you.
Thank you so much, Serbia. I'm already seeing the synergies between the presentations from Han and Serbia in terms of how we can be working together to advance and operationalize the equity works. Wonderful. So I'm going to turn it over now to Dr. Ketia Achebe from Peace Corps.
Thank you. Let me start by thanking you, Dr. Gerard, for organizing such an important and engaging workshop. Thank you to all the speakers also. The new PEPFAR strategy, especially Pillar 1, resonates so much with what I would term as the DNA of the Peace Corps, including our current 5-year strategy. The ideas presented and recommendations made from the breakout sessions align so much with our work. 80% of Peace Corps' program globally focuses on young people, adolescent girls, and young women. To respond to your question, the recommendations actually strengthens our agency's approach to health equity implementation in COP23. We're building and working meaningfully and plan to work even more with the Burden Youth Global Movement. In line with Pillar 1, we will work to support Focus Area 1, AGYW, 3, Key Population, and 4, Barriers to Health Equity, strengthening an enabling environment for improved health and well-being by addressing programmatic social and structural barriers such as stigma, gender-based violence, and inequities in health. As Peter Sands of the Global Fund shared in his introductory remarks, we must address not only the inequities in accessing treatments or medical interventions, but also importantly address the other root causes of inequities that exist in the community. Peace Corps, as a PEPFAR agency, will continue to place our volunteers in communities. Our volunteers will work with community-based organizations. We will invest and will continue to invest in working with the CBOs in the front line, youth movements, AGYWs, including those living with disabilities. Secondly, our volunteers located in the last mile communities will continue to work to better understand and address in partnership with the communities, the inequities, address stigma, discrimination, support gender-based violence prevention that directly affects positive health outcomes. So in general, we're looking forward to supporting PEPFAR in implementing this pillar of the new strategy. Thank you, and over to you, Gerard.
Thank you so much, Kechi. Really appreciate Peace Corps' support in partnership here. Our last Deputy Principal is Vienna Nightingale from the Department of Defense. Vienna, the floor is yours.
Thank you so much. And thank you, Ambassador Nkengasong, for your deep commitment to health equity. It's been really exciting to participate in this rich discussion. So I just wanted to highlight a couple things about DoD and our role within PEPFAR and global health. Our mission is to prevent new infections in our partner militaries around the globe and to build the capacity of the military health systems and provide services to members of the military, their dependents, and members of the communities in the catchment areas of the clinics. And so for those not familiar with our program, many of our clinics that we support provide services to 70 to 95% of the patients are non-military members, and they're members of the community, and many are members of the priority populations that we've been highlighting this morning: adolescent girls and young women, children, and members of the key populations. We found in many of our military surveys that the prevalence rates of HIV is often similar to and sometimes higher than the rates in the general population. So this is a clear indicator that militaries are a high-risk population when you consider that all new recruits start out as HIV negative. We also find in our surveys that there's often a bimodal distribution for the military members living with HIV, where they're often young soldiers or senior members of the military. And we note that a significant proportion of the militaries respond to report engaging in high-risk sex behaviors, including engaging in commercial and transactional sex with multiple partners. They also engage in problematic alcohol consumption and inconsistent use of condoms. So we're really excited about the new PEPFAR strategy and have begun to think about ways to develop our implementation agenda for the military populations and all those receiving services in these facilities. And I think just within the first pillar, the focus area 1, advancing gender equitable programming, and area 4, combination prevention, and area 6, dismantling structural barriers, we've identified several opportunities there. We know that the inequities that we see within health systems are deeply rooted in social, political, economic, and education systems. And to really change these, we have to look at implicit bias and stigma. And we've been doing this for some time, and we've been delivering multi-level ongoing interventions that really do have our workers in the healthcare facilities focus on their own attitudes and their biases. And we started to see changes in the way services are delivered, as well as changes at the policy level. And so we will continue to really focus on areas 1 and 6 to continue those efforts. Area 5, doubling down on the combination prevention approach, I think is really important. There is one particular line in the strategy that says developing prevention efforts designed to effectively reach young boys and older men. I think this was, really written to highlight our particular population that we serve. So we have been doing a lot of integrating VMMC services into recruitment programs, and we are hoping to strengthen our combination prevention program with militaries, and are looking at long-acting PrEP during recruitment, during deployments, and during peacekeeping missions. And we want to make sure that the services are person-centered services and meet the unique needs of the individuals being served. So with that, I want to stop here and just note that we're excited. We're excited to implement the new strategy. And I want to just really recognize Gerard and his team for putting this excellent workshop together. And excited about the development of an implementation plan for this equity pillar. So back over to you, Gerard, and thank you.
Thank you so much, Dr. Nightingale. Thank you to our fabulous interagency leadership. We know that behind each of you is stands a global team of committed staff across countries in the world, committed to advancing this work. And as we go into a season of COP planning, we're looking forward to working with each of your teams and Ambassador's leadership team here at SGAC to drive this work forward. So for our final remarks, I want to just hand it over to Ambassador Kingazong. Ambassador, this was your vision. When you came to me a couple of weeks ago, you said, let's organize a workshop, and you intentionally called it a workshop because you wanted to create the space to hear from partners, from civil society, from countries, from community organizations. And while we were a bit delayed on timing, I think we've created a space and the beginning, as you said, of that. And we look forward to hearing your reflections, sir, and taking this work forward. Over to you.
No, thank you, Gerard, for your leadership and for following through on implementing this, my request, which I made just a few weeks ago to if anyone doubted that equity was a priority for me, I think today you will agree that it is not just words, but it's action for two reasons. One, I have created a position, a senior leadership position on equity, which Gerard is sitting on now. And immediately he accepted that. I told him, you have to move quickly and with clarity of where we are going with this. And he said, what must I do? I said, well, convene a high-level meeting and let's start having an honest conversation around this and then move that forward to see what actions or recommendations will emerge from this so that we can now help us, it will help us in implementing our 5-year strategic plan, which we have just released. We are not co-creating. The reimagining phase led us to the development of the document, which is the PEPFAR strategy. We are now in the phase of moving that strategy forward and implementing it. You will hear, as I said earlier today, you will have a series of such workshops as we in the new year around specific themes that will require that we all come together, ask the right questions, find solutions, and share experiences. That is what it is about. And if anyone doubted at least the outcome of this, I personally have learned a lot. It's been a very rich conversation. I want you all to step back and hear the experiences from Maureen in Kenya, from Steve, another Kenya colleague, a legal expert from Kenya that talked to us, shared the experience with the Supreme Court today in Kenya, and made a very passionate plea and say that we are going to make this bridge the gap in inequity by building from one block after another, and all of us committing ourselves. In other words, what you were saying is that we all have to be leaders in the different areas that we work, and bring this all together. If we can work with the judges, Supreme Court judges, the police officers, the community leaders, and slowly and in one block by block, we're going to make this all happen. There are two things that we will barriers that we really should be working together to collapse. One is discrimination and stigmatization. And I always quote Maya Angelou, who said, prejudice is the burden that confuses the past, threatens the future, and renders the present inaccessible. I think that prejudice is something we should really, that barrier is something we should work collectively to deconstruct. I also like to say that we should be celebrating our differences, and the differences in a way that do not impede us from recognizing and accepting that the differences are there, but we can make good use of those differences, that they are not the differences that divide us, but it's inability to recognize and accept those differences that become a problem and feed into that whole discrimination piece, that stigmatization piece, as well as the prejudices that Maya Angelou mentioned. So I think I'm leaving this workshop as the first, a kick-off of the series of workshops that we will be having as part of moving the strategic, creating a platform for a dialogue to happen around specific topics that relate to the implementation of the 5-year strategy. So I believe this workshop very fulfilled and very enriched, that I've learned a lot, and the recommendations will be grouped together, polished, and summarized so that we can share with all of you. If I was in country X, I'll be looking up to the recommendations of this workshop as we prepare the COP and say, look, if the one way to implement my COP in this area will be to go back to the recommendation and extract a few of them and use that as guidance in developing my COP processes. So I think, again, let me just end by thanking Gerard and your group for pulling all of this together, and for all of you for the active engagement and participation. So thank you, and have a lovely end of year festivity season.
Thank you, Richard, for sharing those recommendations around political leadership, making sure we have that we're using the most recent data and opportunities and strategies for engaging with law enforcement. Let's see, I want to turn now first to Asia Russell and then Bjorn Roos Snyder, and then we'll take a moment to synthesize some of the comments coming up in the chat. Asia, over to you.
Thanks, Erin, and thanks for all of the powerful contributions. I want to build on them with a concrete reflection and recommendation about the levers that PEPFAR has that they could possibly pull on in order to advance some of these recommendations and really demands that we're hearing from communities today. One reflection is that during the COP22 cycle, the use of so-called programmatic controls for key areas where sufficient progress hadn't been noted, in that case, PrEP for all populations, not only key populations, did result in a marked expansion of leadership in some PEPFAR countries and programs around PrEP. So I wonder if that's a lesson learned, for example, around COP23, and perhaps the need for a programmatic control around structural interventions and investing in the leadership of key populations, which are both aspects that are outlined in the ambassador's 5x3 strategy. Because what we're seeing is a lot of consensus around the reality that these priorities are needed, but a gap between the words and the deeds. And that's my second recommendation, is that unfortunately, without expanded funding, this really amounts to an unfunded mandate, particularly when, as others have said, the Key Population Investment Fund was like key population leadership really being pushed off a financial cliff when programs came to an end in 2021 and there was no follow-on strategic approach. So I think that's the other concrete recommendation, is there needs to be a specific, ambitious target set for standalone funding for these interventions that can be tracked and reported on, that prioritizes and really prejudices key population, community, leadership, and ownership. Thank you.
Thank you, Asia. We appreciate you synthesizing and also making very, very concrete recommendations here. Bjorn, you're next in the queue. The floor is over to you.
Thank you. In addition to what many of my colleagues have said about sustained country level investment in human rights, and particularly the kind of legal changes that are needed for people to be able to really access services, I have a very practical recommendation, which is maybe not totally welcome by everyone, but PEPFAR teams at the mission level need key populations training, all of them. It is a sustained issue to have only one human rights officer at a mission who, if they go on holiday, nothing can be done for groups that may be facing arson in their drop-in centers that day. It is something that every PEPFAR person needs to be thinking about. How is my program meeting the needs of people who face structural barriers to care? It cannot be isolated to one person or one small team. USAID already has a do no harm training, and there's no reason why it shouldn't be required for all PEPFAR staff. We have existing ability to do this, and it's unfair that key populations who show up in programs that are not just key populations programs don't have the type of sensitivity, sort of thoughtfulness, and sort of baseline awareness of how key populations face barriers to PEPFAR programs and care. So that's just a concrete something that could happen within the US government full control.
Thanks, Bjorn. That's a very practical recommendation, and I think something that we've started a little bit with the gender and sexual diversity training. And I think also as we embrace this equity pillar, I know something Bill Paul has often said is that we need to be thinking about equity all the time, and kind of infusing it everywhere. So I appreciate that very practical recommendation. Bill, actually, I did want to turn to you. I know you've been watching the chat. Any opportunities for synthesis of what's been in the chat, or maybe questions to sort of push the dialogue a little further in the time that we have?
Yes, thanks, Erin. The chat has been very rich and very fast, and I am not going to do it justice, but obviously we will capture it, and we will look at it very closely. Just a few observations on partnerships, thinking broader and thinking more differently about our partnerships, including organizations that are engaged on climate change, experts who are experts in scaling and replicating success, the role of religious organizations potentially in changing attitudes and cultures that are discriminatory, aligning PEPFAR with diplomatic experts, and better aligning those activities within the State Department, private investors, alignment of donors, but always seeking voices that are voices of innovators and voices from the community. Really lots of great interventions in the chat on partnerships, on programming, the idea, and this is like for PEPFAR people, sometimes a challenge because we are so singularly focused on HIV, the need to focus singularly on people whose lives are bigger than HIV and who have more things happening in their lives. So really being person-centered, integrating services, finding ways to address mental health and a variety of other things in order to be more effective. Many interventions in the chat on data. Certainly population size estimates are a big concern and a recurrent challenge, but also looking at how we measure our progress on the bigger picture structural interventions with the 80-60-80 and the 10-10-10. How is PEPFAR going to proceed in those domains, but also paying attention to innovation in terms of measurement, including community-led mapping exercises and things like that. Loud and clear on funding, right? That scaling and funding, because key population programming is not at scale, and how does PEPFAR intend, and how can we together bring to scale what needs to be in place in terms of key population programming. And that includes not just availability of funds, it also includes how we approach our funding across donors, but also who we fund and how, the structure of grant making for smaller grants and for organizations to build capacity to be prime recipients. Clearly, this is I think it's the second pillar, really important to Ambassador Kingasong on the sustaining impact side, to make sure that the implementers are really representing the countries and the localities and the communities that we're serving. I know there is a lot more in the chat. We will record it, but I just wanted to give those few observations.
Thank you. I also note, let's see, in the meanwhile, I believe Walter's hand went up, or maybe it went back down again. Walter, if you did have a comment, the floor is yours.
Yes, thank you so much. I just want to make a very brief comment here. As I'm putting in the chat, PEPFAR in Africa is similar to Ryan White in the US. And PEPFAR in Africa should be re-engineered for strategic operations to center on teaching hospitals and certified and proven healthcare facilities, just as it is done in the US, with NGOs and their services wrapped around these teaching institutions. This way we can guarantee the building of already existing infrastructure, the building of already existing human professional infrastructures, and to build sustainability, not only in HIV, but also in infectious disease and other healthcare programs. So my contribution is that PEPFAR should be re-engineered around teaching institutions, teaching hospitals in participating African countries, instead of centering it on NGOs. And with that, I think we can be sure of future sustainability. Also, I think that PEPFAR should harness the professionals, the HIV and healthcare professionals, diaspora HIV and healthcare professionals that are already at key institutions in the United States or in Europe, and harness them as advisors.
As likely as their male counterparts in Eastern and Southern African. This is due to complex factors, right, that require a multi-sector response that includes biomedical, behavioral, and structural approaches. You've heard a lot this morning about PEPFAR's newly released 5-year strategy. In response to that disproportionate risk faced by adolescent girls and young women, the PEPFAR strategy emphasizes as one of the focus areas a gender equity approach that meets the unique needs and vulnerabilities of this population. So just, Sam, I don't know if you can go ahead and share that slide, that would be great. But just to say a couple of things about what the strategy says about gender equitable approaches for adolescent girls and young women. It talks about integrating gender equitable programming throughout HIV service provision, whether it's prevention, testing, or treatment, but also at policy and systems levels. It also emphasizes preventing and responding to gender-based violence, which we heard a lot about this morning, integrating HIV prevention services for adolescent girls and young women with sexual and reproductive health services, scaling up biomedical prevention tools, connecting vulnerable adolescent girls and young women with employment and income generation opportunities, addressing social norms change at the community level, including tackling harmful gender norms. And that, you know, these structural interventions need to engage not only adolescent girls and young women, but also adolescent boys and young men, as well as community leaders. So the strategy tells us what to focus on, and we can't emphasize how critically important it is that gender equity and a focus on adolescent girls and young women is included explicitly in the PEPFAR strategy. But because it's a high-level strategy document, it doesn't tell us exactly how to make this happen, exactly what to do. So for today's session, what we're looking to hear from you are your big picture ideas on how we can bring that strategy to life, especially the part about gender equity and adolescent girls and young women. What specific actions will it take us to achieve this equity in order to end the global pandemic as a public health threat by 2030? As many of you know, we're going to be sharing our PEPFAR draft country operational planning guidance, our COP guidance, for your input in January. So there is a chance to input again at that level. So today's not really specifically about the COP guidance. It's more big picture. We want to hear your ideas and suggestions for how to operationalize what's in the strategy to achieve our goals for 2030 as they relate to equity for adolescent girls and young women. Before we open the floor to everyone in this workshop, we're going to hear from 3 discussants who will help us get the discussion started. We've shared 4 questions in advance. Sam, I don't know what's happening with the slides. Are you able to share? Yeah, you can just go ahead to the questions. Next slide. So we're going to focus on these questions today, and I think that our discussants are going to give some comments on some of them. We remind our invited discussants to kindly keep within the 3-minute time limit, but we're now first going to hear from Nyasha Finisa Sitole from Zimbabwe. She's the co-founder and executive coordinator of the Development Agenda for Girls and Women in Africa. It's a network. It's called DAWA. So please, Nyasha, go ahead. Thank you.
Brilliant. Thank you so much, Janet. Hi, everyone. I hope you can hear me. Please kindly confirm you can hear me.
Yes.
Thank you so much. So I'm not going to put my video because I'm also sitting in a car. I was driving, so I parked, and then my network can be difficult. So Really thank you to PEPFAR for organizing this workshop. And I'm so excited because when the person I've been working with at PEPFAR shared with me the draft strategy, and I saw the strategic pillar 1, health equity for priority populations, and there's really focus area 1 and 2 that is looking at youth, young people, and gender equality really excited me, because we all know that we are in very critical times where we have data telling us that every 2 minutes an adolescent girl, young woman is getting infected with HIV. And this is because we are facing dangerous inequalities, including social, legal, economic, gender inequalities. And I come from a country where there's also really the HIV burden around adolescent girls and young women, where 33% of new HIV infections for the year 2021 were contributed by adolescent girls and young women between the ages 15 to 24. So this brings us to the question, like, what are we going to do about designing, implementing, and holding each other accountable if we're going to achieve health equity, looking at ending AIDS by 2030. So there was the reflection around what new partnerships do we want to see. So when I was looking at this focus area number 2, talking about launching a youth movement, I was, hey, this is really exciting, because this is something that we probably are looking forward to as young people in the HIV movement, and also other intersecting movements like Generation Equality Forum, like SRI-HR movements. So firstly, what I would like to really propose is to say, when we talk about launching this movement, may we please not reinvent the wheel, because we already exist and we already know what we need, and we're already organized. But probably what could be lacking amongst the youth movement is just to have this technical support for us to get structured and get connected across our local, national, and regional spaces. So we don't really need to sit down and say, let's create a new movement, but the movements are there. But what is needed is probably resources and technical support on bringing all these movements together into something that becomes very global and representative of everybody. And what we also need when we talk about youth movement building in the HIV response, and particularly looking at adolescent girls and young women, is to also have that recognition that we have intersecting identities. Most often for adolescent girls and young women, when it comes to representation in the spaces, we always get torn in between being a youth or being a woman or representing as women. So we're also saying, is we're going to be structuring and coming up with these coalitions, frameworks, and all the ways of engaging young people in the movement, in the HIV movement. Let's also remember where we are really placing adolescent girls and young women exclusively in their diversity to be able to represent themselves, not being shadowed by other populations. So I also talk about what priority areas that are needed. I would say we really need direct support and investments for adolescent girls and young women-led organization. And this could include technical support, funding support, and also creating that space for us to be able to resource mobilize together. When it comes to funding, we need to think about issues on trusting young people to know that they can deliver. I can give a very good example with DAWA. When I co-founded in 2019, I'm part of the Global HIV Prevention Coalition, and there was a Catholic funding that was there for AGYW in Zimbabwe. And what they did, UNAIDS and the GPC, was to trust that this young person, Nyasha, and the team that she's bringing on board can be capable of actually delivering this project without me actually having all those audited reports, financial history, etc. And we did deliver. So what worked there was an issue of trust, and this is where we are now. We are a movement of more than 600 plus adolescent girls and young women across Zimbabwe and across the Eastern and Southern African region, including Zambia, Zimbabwe, and Malawi. So this is the kind of trust that we need to be giving young people if they are going to deliver and implement together. We also know about the investments that have worked, the programs that have worked, talking about programs like the Dreams Project, talking about the U equals U science that is not lying. We need to be able to be pushing for the sustainability of those programs. Because for me, when I look at programs like U equals U and thinking about the conversation that Maureen just shared, the experience about losing children because you're a mother living with HIV, right now U equals U is giving us hope. The science is giving us hope that I can breastfeed my child without being scared that they can get infected. I can safely get in a relationship without being scared that I can be discriminated. So we need to also be championing to see that these investments that have been made that work are really amplified. And lastly, I will talk about access to new technologies that are coming. All we need as adolescent girls and young women are choices. We don't care whether this is going to be Keb LA, there's going to be vaginal ring, there's going to be the condom, the male, the female condom. All we need is a basket of all these interventions together. So the conversation that has been challenging right now is, how are we going to get the vaginal ring? Who is going to pay for Keb LA? And I come from a country which is one of the first African countries to actually have approved both Keb LA and the vaginal ring. But my worries right now is, how can I mobilize young women to start to know about this product when we're not so sure who is really going to be funding them? So this is the time when we call on PEPFAR, because PEPFAR is one of the global leaders that we know, or the biggest or largest international funder on HIV prevention. And this is the time when we call on PEPFAR to say, if you set the pace on the funding around the HIV prevention choices for women and girls, you're really setting the pace for ending AIDS by 2030, because this is going to motivate others to engage. At the AIDS 2022 conference, I met this young woman from Zambia who was saying, I stay in Zambia and my husband is in South Africa, but because of our culture and how we are set up, she cannot be in a position to negotiate a condom when the husband comes. So she was telling me, you know what, vaginal ring with that 50% efficacy, it's enough for me, because I'd rather have something than not have anything at all. So as I conclude with our remarks on how we can support youth movement building, what is needed to be done when we talk about AGYW leadership, and where do we need to put the investments, and what choices that we need when it comes to new HIV prevention methods, I'll just say, for us to achieve equity, we need to deal with the root causes of inequalities, and we need to be able to dismantle them once and for all. That is the only way we can be able to end AIDS by 2030. Thank you.
Thank you so much, Nyasha, for reminding us about that there's already youth leadership out there, that we need to make sure that we are considering the role of intersectionality in the work that we do, and that adolescent girls and young women need and deserve choices in prevention. We'd like to move now to hear comments from Ruth Amaramong from Kenya. She is an assistant chief in the Kawa East in Kisumu County, and is a former DREAMS participant. So Ruth, please go ahead.
Okay, thank you for the opportunity. Are you hearing me?
We are hearing you.
Okay.
Yes, please go ahead.
Okay, thank you for this opportunity, and thank the PEPFAR for programming this, giving us the opportunity to talk our views. I'm Ruth Umara Mogi, a young mother who has experienced a lot in this one, and the experiences I've experienced should encourage the AGYW, the girls and the young women, because of the program we had with the PEPFAR Dreams program. This has helped me a lot as a young woman, a young mother, because in the community, there are some things which we as mothers, we are not allowed to do. Like when you are married and you have a dream in your future, you cannot go on because the males are the people who are encouraged to go to school. And this support, which we've been supported by the Dreams, has helped us a lot. And the services we have got directly to the Dreams program, and also indirect from other organizations as in the program, has helped us. And the services we've been getting from the PEPFAR, like sugar, education on contraceptive, PrEP education, correct use of the condom. Because the male, if you start using the condom, they say that it is a norm, which now you are a prostitute. So these ones help us a lot. Financial education, HIV and testing, the social asset building. The support they are giving to the girls has helped us a lot. because I had a dream in future, but I could not because of the income I was getting. So the support has made me to attain whatever I was dreaming to be. Like now, I am now assistant chief of my area. And this platform I will use to address gender norms. There are things which there are things like women are submissive to the male. These I'll be teaching them on how to do them, as I'll be having the barazas. So I'll address them to the young women, so that they can be stable. Then the gender-based violence also, because I've been educated through dreams, I'll be encouraging the girls to know when they are violated, where to go, and the action which should be taken, because now we are educated. Then also to join the support groups where they can get the loans, pay their school fees, and attain their dreams in future. Also to seek health, to seek the health behavior, like they should be going to family planning, because we are taught about how we can go to attend the family planning, so that we can give out the children that we can support, so that they can not fall in the things which they cannot do. Then also in this my platform, I will encourage the girls that they are also people who they can even get this leadership through the support of the program, and also they should also do all the things like the men do, because they are capable. Also, in this my platform, I encourage the girls and the women for empowerment. This will encourage them to empower them, so that everything they need in future they can get. Also, the services, the intervention will help them do the services, the right services, like child protection. They can be supported, and also this intervention will help them, prevent them from early pregnancy and early marriages, because now they can also have their support through their leadership. Thank you for the opportunity.
Thank you so much, Ruth, for sharing your inspirational story and how you are how you have gone from using what you learned through dreams to become an assistant chief, and that you are taking all of that and advancing the opportunities and the rights of adolescent girls and young women in your community. So it's such an inspiring story. And also your comments on how important the comprehensive approach was to you, addressing the complex needs of adolescent girls and young women, like needing economic strengthening, but also addressing structural issues like gender norms. So thank you so much for those comments. Finally, we would like to hear comments from Iva Carla Pedro Monteiro from Mozambique. who is a DREAMS National Youth Coordinator. Iva, go ahead, please.
So hello, good morning, good afternoon, and good evening for everyone. I will not switch on my camera because my network problems, and I'm saying apologize now because I'm not English speaker, so I will do my best to explain my points to everyone understand. First, thank you very much for the invitation and for the excellent opportunity to be here to discuss a subject as pertinent or as this one. So let me begin by saying that as young women working with other young women in the DREAMS program Mozambique, this is a really big opportunity to be here stating what we are living and our needs. And it's essential to say that so far, PEPFAR is doing a very great job in the inclusion of adolescent girls and young women in Mozambique. And that through DREAMS, we have successfully managed to empower and reduce the vulnerability index of thousands of girls in my country. And also that, as we saw in Ruth's speech, that the model that exists is very good for the girls that are in the DREAMS program. But however, with population growth and the increased number of young people, mainly young women, I'm talking about sub-Saharan Africa, I think, and Mozambique, that is my context. It's important to start giving a voice to these girls and women and more opportunities for them for decision-making in the creation and on programs that aim their well-being. It's not just important create programs for them, but it's important to include them in the discussion, because more than us, they know what they need. They know how we can empower them. They know how we can help them successfully end with HIV or prevent HIV. And I think that the inclusion of adolescent girls and young people in advancing gender programming goes beyond HIV prevention and access to information on sexual and reproductive health. It also includes creation of empowerment environment where girls, participants, beneficiaries, DREAMS ambassadors, mentors, young women of all kinds have access to empowering tools such as socioeconomic skills, life skills that will help them to be in school and achieve higher education. It's also important to have an effective system of sisterhood, because female reference figures is a priority and is really important for this kind of situation. It's important to have cycles of sister and mentorship that teach our girls that live in a world free of HIV is possible, and that they can go to school, they can make their own decisions, and they can live a life where they can be leaders. I think that we need to focus in partnership with grassroots youth-led organizations to create change makers. So I totally agree with Naisha that we need to trust in our young leaders because they are capable to be the change makers of the futures. And straight the partnership that we have with the government to create gender inclusive policies, where we create forums in which young people are heard to create policies that are more appropriate and realistic for our needs. So we need to trust in our young people more than just create programs for them. And just to finalize, it's important to mention that a lot is being done in terms of innovation, such as self-testing and PrEP, and all the availability of information about treatment and prevention of HIV/AIDS. But now we need to focus in changing the behavior, demystifying and breaking taboos about sexual reproductive health and HIV, and ensure that young women have access to treatment and prevention service without fear, reprisals, and discrimination. We need to include the leaders of the community, the parents, the teachers, we need to start talking to them, because most of the time, the girls, they are not the decision holders. They don't have power. So we need to talk with who have power in the community to understand and help these girls in the prevention of HIV. And more than that, we need to start creating innovative solutions for youth, such as like more youth-friendly package for PrEP or injectable PrEP, to make sure that the girls have access to things that will help her and will not make the community discriminate her when she accessed this kind of prevention tools. Thank you.
Thank you, Iva, and thank you, Ruth and Nyasha, for your incredible voices. It's added so much to the conversation. Now, I want to sort of start opening the floor to kind of the broader discussion. I know we have about 100 participants on the line today, and we have about 30 minutes for discussion before we have to summarize and then move back. So I know I will not be able to call on everyone who would like to contribute. And so please, I would also encourage you all to enter your comments into the chat, which we will of course be monitoring, recording, include as part of any follow-up. I also want to note that, you know, we mean this very sincerely when we say we do not intend this to be the only discussion on this topic. You know, as my colleague Janet shared, you know, the strategy was just released. We are starting to think through how to operationalize that best, and we consider this the opening of an ongoing dialogue and discussion on all of these critical themes. The last piece I wanted to say before I open it up for discussion and ask folks to use the function to raise their hand is I wanted to let you know that Janet Fleischman, the other Janet, has graciously agreed to be the rapporteur for this session, and she will be synthesizing some of the key themes to present in the plenary. And just some background on Janet. Janet Fleischman's an independent consultant on women's global health rights and US policy, and a senior associate with the Global Health Policy Center and the Center for Strategic and International Studies. She's done extensive work on PEPFAR and adolescent girls and young women, and has published on that topic widely. So now I'd like to open it up for discussion. If folks can use the function in the Zoom to raise their hand, so that I'll then call on you, and then you can unmute and speak. So please go ahead and do that now for anyone who wants to come in.
Don't be shy. Take a look at those questions that are up on the screen and think about what are some of these ways that we could bring to life the strategy for the equity of adolescent girls and young women. And you can also put your comments in the chat. We will be tracking those as well.
Okay, I see a few hands starting to come. So maybe we'll start with Augustina. Why don't you go first?
Yeah, thank you. One thing I just wanted to bring up that I think sometimes gets a little bit lost is the pregnant AGYW. I think they're a very specific population that kind of falls in this in-between of PEPFAR programs. And so I think often we are not able to support them as well as we could. So I think making sure as we move forward that we also recognize their individual needs and how our programs, you know, like the ANC, PMTCT, and DREAMS programs can work together better to make sure we're meeting their needs. Because, you know, ANC is often a common touch point for healthcare that we may be reaching AGYW who would not be involved in healthcare otherwise. Thanks.
Thank you, Augustina. Now I'll call on Padmini. Why don't you go ahead?
Yeah, thank you so much. Actually, I think this is a great discussion, and thanks for the opportunity of reaching out to those of us in academia and civil society. As a physician and a public health professional, one of the things which comes to my mind is it's great that all these are there 20 years down the road, but I feel PEPFAR initiatives need to be more inclusive because factored into the delivery of primary healthcare, because that's a big challenge we find, and more gender focused. It's great to have this initiative. Kudos to the Biden-Harris administration. Maybe reaching out to more of us who are in academia and the NGO world would strengthen this initiative to be more inclusive. Again, thank you so much. This has been a great way to spend a cold December morning from New York. Thank you again.
Thank you, Padmini, and it's a great point around kind of the integration of services, very critical point for the future. Now I'll call on Friederike. I apologize if I
you did well. You did well. My name is Friederike. You did well. You called me very well. I am in San Jose, California. I am a lawyer. So I am from Africa, but I live in California. And I used to be a UN gender expert. So I am trying to raise the point, like point number one, right? The global and local necessary to advance equity agenda. I think that policies, especially talking about Africa, where we have custom, we have our culture, we have so many things that are hard to move. I think that investing in information assessment and also policy change regulations, that is something that is so important. I am working right now with my own nonprofit, SIAP Africa, and that is something that is huge because when I'm on the ground, I need to start talking to the local chief, I need to talk to churches, I need to talk to mosque, I need to talk to imam, I need to go and talk to the senator. And so we need to talk to, I mean that policy change is number one before policy change number, and then what the lady before me said, we who are based here in America, how can we really use everything that PEPFAR has? I have never heard about PEPFAR until today. So how can we utilize, how can we be more involved to become really strong partners here home before we take it to Africa and somewhere else? Thank you.
Thank you, Friederike. Now over to Sammy.
Thank you so much. Hi, everyone. I'm Sammy Lucy, and I'm so happy to be here today. I wanted to share specifically within relation to the availability of data about dreams. I really appreciate the direct feedback and reporting that we received just at the beginning of this breakout room from the three panelists about the importance of dreams, and through the data summit and the data review process that's been ongoing that from SGAC, we've noticed that some dreams indicators are now being, there was a recommendation that these data be made optional for reporting. And we are very concerned that making any data collection about the impact of dreams optional would weaken the effectiveness of the program and weaken our ability to talk about the successes of dreams as a vital PEPFAR initiative. So we want to really encourage all PEPFAR indicators related to dreams, all standard reporting on dreams be made consistent and mandatory across all dreams countries so that we can better understand and contextualize the firsthand accounts of dreams participants, dreams ambassadors, all of those who are engaging in this program. So I just wanted to share that as a specific ask for SGAC to carry forward. Thank you all so much.
Thank you, Sammy. Now over to Arlene.
Thank you very much. And thank you to all the presenters. Really nice to hear, their perspectives. I also have a comment on dreams, and it's really exciting to hear the impact that this program has had on young people. I must mention that, you know, sometimes you hear people talking about dreams is very expensive, you know, maybe we should just give PrEP to young people. But when you hear young people speak like this, I think it encourages you, because we need the social and structural interventions that dreams brings together. It's not a one size fits all, but dreams, I think, you know, gives girls a lot of skills that help them avoid HIV infection from different aspects, whether it's behavioral, it's structural, and things like that. And I usually have a question, you know, when people say dreams is expensive, I say, what is cheap? You know, should we let these young girls get infected and then put them on treatment for life? Is that going to be cheaper? Anyway, maybe that's the discussion for another day. But I just wanted to encourage young people that even as they are, you know, looking at getting funded, being trusted and whatever, to really use, to collaborate among themselves. The issue should not be competition, like, oh, we want to get the funding, but really collaborate with each other. You know, make sure you identify where your different comparative advantages lie, so that, you know, together you become more, you become a stronger force. I think that is something. But also, when you look at programs like the Global Fund, I think for programs for these young people, I think maybe we really need to see how we can bring our resources together, whether it's human resources, it's financial resources, and whatever, to really, you know, take these interventions like the DREAMS program to more AGYW. I think among the donors, I would say, you know, we should really work together more to see where there are gaps and where we can use the resources that are available to fill these gaps. Thank you.
Yeah, thank you, Arlene, for that call to action. Now over to Scholastica.
Hi, thank you. Scholastica Williams from the National Council of People Living with HIV in Tanzania. I want to echo what Arlene has said, and I want to thank the presenters because they have highlighted the fact that the intended beneficiaries in inverted commas, for me, they are the way to go in the future. The National Council of People Living with HIV in Tanzania has proven time and time again that the best interventions that work with the youth is those that are implemented through and managed by the youth for the youth. We found this to be the best way of working. If you want to reach KVP, then you want to find KVP who you have trained, who have been trained by someone else and they're strong. And you want to build their capacity and help them manage the programming to reach others. This seems to work faster, further, and it's more sustainable. I think the new, along the new partnerships that we're thinking to build in the future, we need to earmark some resources that will build capacity of the intended beneficiaries to implement and manage programming that are geared to reach their peers. Thank you.
And thank you, Scholastica. Now over to Bergen.
Hi, everyone. Thanks so much. Thank you for creating this important space. I'd like to address question number 2. Given the Biden administration's commitment to promoting sexual and reproductive health and rights globally, and the expanding research from the World Health Organization and the Pleasure Project that shows that including sexual pleasure and sex health education improves condom use, increases knowledge and positive attitudes about sex, and in turn leads to safer sex, I'd like to flag that PEPFAR support for an enabling social environment must include discussions of the positive aspects of sexual health in dreams and any other work that is targeting adolescent girls and young women. Thanks so much.
Thank you, Bergen. Now over to Maxwell.
Yeah, good morning, good afternoon, everyone. So for me, I think it's the first question. And I applaud the 3 presenters, first of all. I think the answers we're looking for, we just got the answers we need. The question I have is, in terms of new partnerships, what is new that we're looking at? We just heard from the young people in this forum, the young, powerful leaders within their own rights, what we need to do. And I agree with everyone, the previous speakers, that we already have the answers we're looking for. It's how we work together that's going to make a difference. I think we shouldn't reinvent the wheel. We should be listening to these three young people who have just spoken to us, these powerful leaders in their own right. They're speaking for voices that we are seeking to hear more from. My plea to the team is, instead of looking at new, we need to look at the words we're using. Let's talk to young leaders like the ones who've just presented and ask the right questions through them by framing from the words like risk. So when you talk about investment risks, when you heard about how successful Mozambique has been and has gone to the southern part of Africa to build a youth movement from an individual, I think we need to be more intentional in our engagement with young people, both men and young girls and women and adolescents, by really taking the intended investment risk, as we say, as adults, and putting the money where we need to put. I think we've already gotten the proof in it. I think we need to now walk the talk. That's all I'm going to mention. And thank you and congratulations to the three speakers, because I think we already have our answers in-house.
Thank you, Masquel, and that's very well taken. Now over to Shepard.
Thank you for having us. When you look at the history of the epidemic in Africa prior to any treatments being available, which came around 2001, 2, 3, the one country that had a significant reduction in new infections between 91 and 2001 was Uganda. And part of that was because of their messaging encouraging zero grazing for men to stay within that circle of their family. And the data showed that there was a drop from about 42% of men having multiple relationships to 21%. And with that, a strong decline in infection. So it's a behaviorally driven disease that we need to look at ways to impact behavior that reduces infections. And I think one of the components that helps in that is the faith community and the church. Helping young men understand they need to respect women. Young men grow up to be older men and unfortunately sugar daddies in many cases. So if we can do that and utilize the faith community, that would be important. And also, COVID has pretty much annihilated people's thoughts about HIV/AIDS here in the US and abroad. And to get a better picture of what is actually happening, I think the faith community offers something else, and that's in both their ability to preach in churches, but also their radio connections, which are pretty extensive, particularly in rural areas. So I think utilizing the faith community to at least get the word out is something that we should focus on more. Thank you.
Thank you, Shepard. Over to Monica.
Yes, thank you. Monica Lal from Gilead Sciences. Again, thank you, PEPFAR, for engaging us in this important conversation, and a big thank you to all the speakers. We need to keep hearing your voices. Just a few observations, particularly around innovative programs for girls and young women. I think the power of peer educators and counselors, I think that will continue to play a huge role in helping achieve our goals. I think the influence of social media, but also the reach of radio programming cannot be overlooked. And I think encompassing the other half of the equation, boys and young men, so echoing what the previous speaker just said, is so essential. I think let's take the learnings from DREAMS to establish perhaps DREAMS 2.0. Let's not the momentum of DREAMS slow down and can move the needle to Dreams 2.0. Thank you.
Thank you. Now over to Lillian.
Hello. Can you hear me?
Yes, we can. Go ahead, Lillian.
Can you hear me?
Yeah, we can. Go ahead.
Yeah, sorry. We are, the meeting is happening at night and we are in the house. I'm trying to make sure I get a silent place.
You're
so
fine.
sorry.
You're fine. Go ahead.
Yeah, thank you so much, and PEPFAR for putting together this important workshop. We appreciate, and it comes timely as you're almost getting into the planning. So seated where I'm seated and listening to the different speakers, the panelists, I think one of the key areas that would want PEPFAR to really focus on is addressing the inequality within adolescent girls and young women in terms of access to prevention services. We very well know, and like some people have already mentioned, that we are talking about a period where we at least very well know that we have the tools available for prevention, but that we continue to register new HIV infections, particularly among adolescent girls and young women. And especially when it comes to Africa, the situation is really alarming. And it is disheartening for a mother who was diagnosed with HIV at an age of around 24, when there was little in terms of knowledge, in terms of resources, in terms of tools. And therefore, when I look back, I strongly feel that it was a period when there was less in terms of everything that was needed to prevent people like me from acquiring HIV. But that in 2022, it is unacceptable. We cannot stop blaming ourselves that we are seeing young women and girls getting infected when we have all the tools that we need, when we have the resources that, in my view, are enough to prevent such infections. This generation of young women and girls will never forgive us. If they do, they will never forget. And it is really absurd that these young girls in 2022, in this era, they'll be telling the stories that Maureen talked about, the stories that we talk about, the stories that we really don't want to remember. And therefore, my call to action is, can we look at the little that we can do, even if it means investing in providing information, even if it means investing in calling to action our governments, even if it means putting some little resources as PEPFAR, probably to do some demonstration studies, especially for the tools that we just, that have been approved by WHO, like the pivoting vaginal ring, so that we have options and choices for adolescent girls and young women, so that tomorrow we can say we did our part as development partners, we did our part as PEPFAR, we did our part as advocates, we did our part as implementers and service providers. But probably you young people did not do your part. But at this moment, we are not doing enough. We are continuously showing data. And I think for me, it is also unacceptable to continue showing data of how many young girls are getting infected daily. And in my country, for example, Uganda, and at the same time, we are not doing anything about it. So I think for me, it is a call to action that we put our hearts, our resources, our energy, our brains, our everything to giving the best that we can, so that we stop continuously talking about what is not working well, talking about the gaps that we are seeing, talking about the new infections is actually, I think we need to stop that. And to stop that, we must do what we can and which we know we can do. Over to you.
Thank you, Lillian. And it was a very powerful contribution, and I appreciate you joining us late at night to do so. So then now over to Jennifer Erie.
Hi, thank you. This is Jennifer Erie in South Sudan. I'm in Juba, and just a few points. I wonder for PEPFAR for USG, have you all thought about maybe hiring young people at PEPFAR? So having folks on your team that actually reflect the beneficiaries that we're trying to serve. And then also, do we have a youth council, a youth advisory committee for PEPFAR at the global level? Maybe that's something that could be taken on. And then I was thinking maybe we could also create like a YALI type of fellowship or internship program, even to have beneficiaries come through and work with the teams and headquarters to help shape the programs going forward, and to be there to provide advice and to give us reality checks, et cetera, at that higher level. I wonder if we can create an innovation fund type of thing for youth-led organizations, something like the Ambassadors Small Grants Program just for youth-led organizations. And then maybe some new partnerships, we could look into other bilateral governments. So for example, here on the ground, speaking to other embassy staff at like Canada, Sweden, they're interested in doing some things with, for example, key populations and youth, but they're not quite sure where to start or where to do, because when they hear PEPFAR, they think that we have it covered. And so I think if we can maybe do some more advocacy with other embassies and governments, maybe we could get something beyond their contributions to Global Fund to supplement what we're doing. So those are just some thoughts that I have. And also maybe one last thing is to target the diaspora for support of youth organizations. So maybe that could also be a new path for partnerships. Thank you.
Thank you, Jennifer. Then I'll go to Caitlin. Go ahead.
Thank you so much. I appreciate this space. I want to make two recommendations for this important conversation. One is for PEPFAR to consider increasing the important role that it plays in health diplomacy in service of adolescent girls and young women to really get at some of the structural barriers that I think drives the persistent inequity in this area. So I'm thinking about age of consent laws, policies impeding the provision of comprehensive sex education in schools and out of schools, as well as restrictions on sexual and reproductive health and rights. And then the second recommendation is to really think deeply about how we can rebuild partnerships that were harmed by the global gag rule under the previous administration. Because I think as we think about investing in community orgs and certainly those serving and led by adolescent girls and young women, as well as key pops, we know from research that those were the same groups that were on the front lines of experiencing the harmful impact of the global gag rule. And I think this obviously includes funding, but also real thought partnerships. So as we're doing consultations, thinking about the way forward like this, I think making a very deliberate and concerted effort to make sure those groups feel welcome and supported and participating in conversations that they may have been excluded from in the past. Thank you.
Thank you, Caitlin. And just before I go to Jennifer, I just want to thank everyone for their contributions in the chat as well. Has been a really rich discussion, and many of the themes folks who've contributed verbally have been also reinforced and augmented in the chat. So thank you all for those contributions. Over to you, Jennifer.
Thanks so much. So I just wanted to make a suggestion as well. I work on several dreams programming programs across several countries, and just wanted to flag that what I'm seeing is that we're still leaving behind AGYW with disabilities. I don't, I'm concerned that it doesn't come up within the screening tool in all countries. I'm not sure if any, but not in the countries that I support. Is it part of the enrollment screening tool that's used, and we're not disaggregating by DREAMS participants with a disability or identify as having a disability. And so I think in addition to that, needing to improve the inclusion of AGYW with disabilities and advocates, not just as program participants, but as steering committees, or really bring them in to inform programming approaches and monitoring programming and helping with CLA, because I think that there's still a lot of gaps in terms of reaching AGYW with disabilities and making sure that they have the opportunity to be included, and that we're prioritizing this group, especially given their higher rates of vulnerability to HIV and gender-based violence. Thank you.
Thank you, Jennifer. I think a terrific point, and a challenge across HIV program, especially for adolescent girls and young women, but many other groups as well that we all have to wrestle with. So, I want to thank all the contributors. It was an incredibly rich discussion, many ideas and food for thought. I'll quickly pass it over to my colleague Janet Saul to make any remarks before we move it to our rapporteur, Janet Fleischman.
Hi. No, thanks. I just want to thank everyone as well for jumping in, either, by raising your hand, or there's a lot of richness in the chat as well, with a lot of themes emerging. And Janet Fleischman has the difficult job of kind of pulling the themes together and reporting out on those. So Janet, I don't know if you want to go ahead and make some observations here before we go to the plenary room.
Thanks, and thanks everyone. Such an interesting discussion, and I really wish that we had more time to drill down on some of these interventions. But I think some of what we've heard can be grouped together in a couple of key areas. One, of course, is the importance of work of resources for and elevation of the youth-led and AGYW-led organizations. And that means resources, of course, but it also means thought partnership. It means considering this idea of internships and youth councils or AGYW councils. I mean, the whole really broadening and deepening what that engagement looks like, I would say, is one theme that clearly came out. Another is around engaging communities more broadly. So it's AGYW in all their, intersectional dimensions. So that's pregnant AGYW, AGYW with disabilities, engaging the gatekeepers in communities, engaging faith-based organizations and community leaders, so that these issues of gender norms really we can work with communities to really move those needles, because the issue of stigma, discrimination, lack of access is still very acute. We heard that very loudly. The broader theme of SRHR, an important thing that PEPFAR needs to dive into and deepen the work that it's doing. That includes the positive aspects that were mentioned, as well as the health diplomacy aspects, which are, I think, very important to include here, and looking at communities whose voices on SRHR are going to have been so important in the past, have been impeded and hurt by some of the global gag rule policies, and who can be important voices.
This is the children's breakout room, Anyeka.
Hi, everyone. Sorry, I couldn't get out of the plenary.
It's okay. We just introduced Michelle Chevalier, Michelle Zavilla, and we're turning over to you, Hillary.
Okay. Hi, everyone. That was a very inspiring opening plenary. It's great to be here in this workshop with you. I think Maureen really laid out some of the main issues for children that I think we will discuss further today, and I think is really highlighted in PEPFAR's 5-year strategy that was released on World AIDS Day, entitled Fulfilling America's Promise to End the HIV/AIDS Pandemic by 2030. The strategy will really guide the United States contribution to reaching the United Nations Sustainable Development Goals of ending global AIDS pandemic as a public health threat by 2030. So just as a quick recap for children, the strategy really emphasizes focusing on scaling evidence-based prevention of mother-to-child transmission, HIV diagnostics and treatment for children and adolescents, and pregnant and breastfeeding women. This will require reimagining the potential of sophisticated differentiated service delivery models to meet mothers, children, families where they are with what they need, and improving children living with HIV estimates and really the data that we use to program, as was mentioned in the plenary. It will also require ending preventable deaths of young children living with HIV. We have the tools to do this, and we need to figure out how to better scale it. We also must ensure pregnant adolescents, adolescent mothers, and their infants have access to destigmatized, youth, and family-friendly HIV prevention care in partnership with the Global Alliance to End AIDS in Children. We will work to elevate the HIV/AIDS children agenda to the highest political level within and across countries. So for today's session, we're looking to hear from you big picture ideas on how we can bring to life the PEPFAR strategy, and specifically our goal to achieve equity for children and to end the global pandemic as a public health threat by 2030. As many of you know, we will be sharing the PEPFAR draft country operational planning guidance for your input in January. So today is really not about that. Today is big picture. We want to hear your ideas and suggestions for how to operationalize what is in the strategy to achieve our goal for 2030 as it relates to equity for children. So before we open the floor to all, we will hear from 3 discussants who will help get the discussion started. First will be Dr. Shafiq Asai from UNICEF, and then we'll hear from Dr. Angela Mushabi from the Zimbabwe Ministry of Health, and then Ms. Helena Ngombe from GNP Plus Namibia. So maybe Michelle, if you can show the slide with the 4 questions that we're going to be addressing today. So we've shared these questions ahead of time, and so I think some of you have already started to contemplate these questions, and we'll ask our discussants to sort of respond to some or all of the questions in a 3-minute time frame, just so that to get our juices sparked, and then we'll turn it over to the larger group. Over to you, Shafiq.
Hillary, thank you so much. It's wonderful to join you today, and it's great to see so many friends also participating in this breakout session. I really welcome the theme of this workshop and its focus on equity. And I sort of want to recognize that actually the fact that we're talking about equity is a marker for some success. You know, equity becomes an issue when some are approaching the finish line while others are lagging behind. So when we hear the data that says 79% of children.
We lost your sound, Shafiq. Shafiq, we can't hear you. Can you hear us?
Can you hear?
Oh, we heard you for a second, then you cut out again.
So I was just sort of reflecting on the fact that we have to recognize that we're achieving some success, and it's because we've achieved that success that we now begin to see the equity issues coming through. So we have the tools. We know we can do it. Botswana has achieved epidemic control, which is a remarkable accomplishment. It's not because we lack the technology. It's about political will. It's about determination. And it's about, I think, a new way of partnering across global and regional and national partners to try to achieve these goals. Now, the Global Alliance to End Pediatric AIDS by the time of the SDGs is recently formed. And what we're trying to do in this alliance is to change the partnership model. We want to have countries lead, and we want to elevate the central role of people living with HIV and communities in fostering a response that is truly sustainable. How do we do this? How do we ensure that the work that we're doing is going to be most impactful? I think the policy and social environment piece is really critical. And it's one area where we don't have to fight between whose inequity are we talking about. On this call, we heard a lot about key populations and how, MSM are being left behind, how female sex workers and the data that was presented by Ambassador Nkengasong are some of the worst addressed as far as the response is concerned. And we sometimes end up in this sort of argument around whose outcomes are the worst. Is it children? Is it key pops? Where should we be focusing our interventions? And I think the policy and social environment piece is one that cuts across all of this. Stigma and discrimination, laws that prevent access to services, whether it's for an adolescent who's too young or for a sex worker who's fearful of attending for services because of her profession. These are the sorts of areas where I think a focused effort to try to address some of those policy issues, those social environment issues, would actually support the entire equity agenda across the board, whether you're a child or whether you're a gay man trying to improve service delivery outcomes. And I think trying to bring those services into more integrated approaches within health is also a critical tool that we should really begin to think about. In the early years of the epidemic, we had to build vertical systems actually because the standard health system threw out people living with HIV. They didn't want to address those issues. I think that's come around now, and I think we really need to think about how to integrate, how to lateralize responses to ensure that the tools that we have are really achieving the greatest access, and that people who have traditionally been left out of that are able to get access to some of those tools in the most effective ways. So I think integration is critical. I think partnering in new ways is critical. I think addressing some of the policy and social issues that hamper equitable access for all populations is, to me, an essential area that we should focus on. And I'll turn it over now to our other colleagues. So back to you.
Thanks so much, Shafiq. Over to you, Angela.
Thank you very much, Hilary, for giving me the platform. And I want to just highlight and echo what was said regarding the disparities in treatment coverage for children. And I think in the UNAIDS report, the World AIDS Day report, we know that over 3/4 of adults are on treatment, and yet only 52% of children are actually accessing life-saving treatment. And to me, that's really a social injustice to a very young and vulnerable population. And therefore, I think moving ahead, we need to really sharpen and focus and deliver a differentiated package of care to our children so that we level the playing field for our children. In order to do this, we need to really deploy and find the missing children. Finding the missing children means that we are doing perhaps what we haven't always done before. We need to scale up family index case testing. We need to do community-based strategies for finding the missing children, and of course to deploy certain innovations such as HIV self-test kits that are coming onto the horizon. And that also means working with caregivers of children to get their buy-in into these strategies. And one of the ways in which I think we can form alliances and collaborate is to really partner with communities and civil society organizations, with leaders in our community, as well as the faith in community. I heard it earlier on when Ambassador John was talking, he showed a picture of participants at the Vatican, and this is really tackling the Rome Action Plan to end pediatric HIV and TB. And you can see in such a platform that it is not only a single stakeholder, it's multi-sectorial, it's communities, it's multilateral agencies, it's bilateral agencies. It is getting the faith community at the table, getting manufacturers of child-friendly formulations on the table, as well as the big pharma, so that we really are working together. And for finding children, of course, especially for the young ones, we need to look at case-finding strategies that even rely on point-of-care testing. One of the things that is critical is in monitoring viral load suppression in children, so that we reach 95% coverage, 95% viral load suppression. And for that, we need support for retention and adherence. And for children, that means working with caregivers of children. It can be parents, it can be others in the community who can support a child. I realize that there's a strong focus on advanced HIV disease. And when you look at advanced HIV disease, the package of care that is delivered is not just focusing only on the medicine, be it cotrimoxazole, antiretroviral treatment, TB treatment. No, it also focuses on other structural determinants for health. So nutrition becomes important. The structural determinants also look at the socioeconomic status. And this is where I think we need to be looking at HIV-sensitive social protection. How can PEPFAR programs leverage on the OVC platform, for example, to be able to deliver a holistic package of care to children living with HIV and not just focusing on the medicines themselves? And therefore, that brings me to the issue of working across different line ministries, working, for example, with departments of social welfare across our HIV programs, and addressing the nutritional needs of our children and their socioeconomic challenges that actually pose health equities for children. And therefore, I want to say that in responding to health equity for children, we must be aware of pandemics such as the COVID-19 pandemic that really derailed programming and affected the most vulnerable, the women and the children. In our programs, services for women and children were severely disrupted in the early stages as facilities that cater for women and children were repurposed for COVID-19. And so how are we preparing ourselves for future shocks and pandemics? And I think that we must learn lessons and do business unusual, because in that time period, we were able to utilize and mobilize the use of virtual platforms, for example, for training, virtual platforms to do telemedicine, and to even counsel, particularly the older child on treatment who needed support for retention and adherence. And so I want to say, really, we need to do everything that we can to end this health inequity for our children. Thank you very much.
Thanks so much, Angela. Over to you, Helena.
Thank you very much for inviting me to represent the perspective of the community, and thank you very much for my colleagues who spoke earlier. Greetings to you all. So as an activist and a mother, I'm glad that I'm part of this movement to end AIDS in children. Despite all the progress, the UNAIDS still reports that share some shocking statistic on how the global AIDS response has forgotten and failed children. The gap between adults and children treatment coverage has really grown, and many children are still dying. I'm happy to be focusing my remarks on community leadership, because that is the foundation for building movement that can deliver equity and results. We all know that AIDS response would not have been achieved to what it has without the leadership of the community. But this is not fully invested in, because this is the most place where we see cuts when funds are tight. Community networks, especially those led by women living with HIV, need to be sustained, strengthened, so that they can contribute in designing and delivering a more effective response for children. In order to reach and support children living with HIV effectively, we need a family-centered approach that starts with mothers, young mothers, mothers from the key population and marginalized population, and not forgetting mothers from rural areas. We must do more to strengthen the peer intervention. Peer helps to bring and retain women in HIV care. It provides information, psychosocial support, and empower women to fully support their children. Community leaders and activists empower our community to know and demand their rights, and holds our governments accountable to the commitments they make. We report the stock out of nevirapine, raising user fees and unequal access to the early infant diagnosis. That is all over, even in Namibia, we had faced challenges like that. Therefore, more political and financial support is needed to protect and support community organizations, advocates for their rights and accountability. It's great to share that the 3 global networks, ICW, GNP+, and Y+, have contributed to the shaping of new global alliances. Together, they successfully advocated for a pillar on human rights and more meaningful engagement of the community throughout the initiative. We hope that this now translates at the national level, as more countries, therefore they should be signing up to join the global alliances. Dear colleagues, the time is now. We must act urgently. We must act together to ensure that children are no longer left out behind by the AIDS response. I thank you, and back to you.
Thank you very, very much to our 3 speakers. You've just given us so much to kick off our conversation. Thanks to Dr. Mushavi for talking about the cross-sectoral nature of how we need to respond, that children live in homes with real social situations, and we need to look at that. Thank you to Shafiq, who talked to us about the Global Alliance and the need for integration. And thank you very much, Helena, for reminding us how important it is to have that community leadership and that political leadership and that urgency to move ahead. So with that, what we're going to do is we're going to open up to hear remarks from all of you who have joined us today. And you have 2 ways of signaling that you have remarks to share with us. One is that you can write into the chat box, so please feel free to do that. The other is that you can raise your hand. I want to just note, we're not going to have time probably to hear from everybody today. So we are going to save the chat box. Okay, so we really want you to know that we do want to hear from everybody that we can, but since we know that we have short time, that we will be saving the chat box. The other thing that we wanted to let you know is that Dr. Eleanor Magongo, who's from the Ministry of Health in Uganda, is going to be our rapporteur, and she's going to be listening to you and taking notes that she's going to share at the rapporteur session. We're also going to have Michelle Zavilla. She's going to be sharing her screen in a minute, and she's going to be taking notes as she hears them. So you'll see that going on. And also just to say, this isn't our last opportunity to have this discussion. This is really going to be and meant to be an ongoing discussion with our community, especially as we look towards the next 5 years and achieving equity for children. So with that, I'm going to go with our first hand up and turn it over to Catherine Connor. Go ahead, Catherine.
Thanks, Gretchen, and thanks, everyone. Can't tell you how exciting it is to be in a conversation with this many people in a breakout room talking about children. I think sometimes we feel like this is the area that gets the least attention. So I want to thank PEPFAR for their leadership and really pushing to address this, not just as a biomedical issue, but an equity issue. It's an important kind of change in our own dialogue. I just want to touch on a few things that our speakers talked about. I'm obviously not going to speak neatly into the questions presented, but I'll try to get to them as I speak. I think, Dr. Angela, has been such a groundbreaking person when it comes to looking at the pediatric data. And I think her work on looking at the different windows of time in the maternal vertical transmission window really kind of set the tone for how we're looking at this population now, that this isn't a monolithic mothers and babies type view. This is a really sophisticated period of time where we can interact with a mother baby pair and hopefully a family centered care to change the health trajectory of everyone involved. And so I would really encourage, this came up a little bit in the previous plenaries too, that we do take that sort of strong data analysis viewpoint, like we did looking at the breastfeeding, perinatal transmission points, looking at the different age groups. The needs of children 0 to 5, school age children, young people are different, whether it be their treatment needs, prevention needs, but also even the types of mothers. I know when the speakers spoke to that again, these aren't monolithic women. Some are key populations. Some have family support, some do not. Some are young mothers who've had to drop out of school. So their medical needs and their psychosocial needs are going to be different if we want them to have successful health outcomes. So really think that data element is critical. I also think some of the things that are touched on about sort of using the tools we have while we're looking for new tools is really important in this area. For some of us who've worked in this a long time, vertical transmission, preventing vertical transmission is the original treatment as prevention, right? The science here is well established, yet we still sort of struggle to meet to correct all the barriers that kind of keep women from getting this well-established service. And so, I think really taking a look and seeing how we're using the tools we have and using them better. Similarly, we need to finish the transition of pediatric DTG. Obviously, COVID derailed that in some places, but using that tool is going to be critically important in this push. And then obviously looking at some of the new things coming out, like long-term injectables. A lot of the populations that we looked at, one is, the lactating and breastfeeding pregnant women. That's an area obviously where there's a lot of seroconversion. And so I think looking at the sort of long-acting PrEP as well as some long-acting treatment options will be really important in this population as well. So those are some opening remarks. I'm sure I'll raise my hand again. I have bad habits, but I wanted to throw those out there while I had the chance. Oh, no, and one more thing, because I'm looking at Gretchen's face. I know that we remarked on OVC, and again, I think this is an area that we need to think about the evolution of it. Obviously the challenges around orphans and vulnerable children have changed over time since this originated. But every time we have this conversation, we go back to it's not just biomedical, it's not just biomedical, yet we're also quick to sort of say, well, you know, we should be using some of the OVC money to help one type of population or one type of intervention. So I would really encourage this group to think about what a more modernized or an evolved OVC portfolio should look like, because it needs to be robust and well understood if we're going to meet all the needs that we talk about in these chats. And we want to do more than just the biomedical. So
thanks so much. Thank you, Catherine, for helping us move on. I see Lori's. You're right, Lori. We need to stop saying OVC, but we'll have to think of it's a mouthful to say orphans and vulnerable children. I see there's a lot of activity in the chat, so I want to hand it over to Hillary and to Michelle Chevalier to give us kind of an update of what you're seeing in the chat so far.
Thanks, Gretchen. And yeah, folks, feel free to raise your hands to speak next as I'm sort of going through some of the highlights that I've seen in the chat. I think we heard about, you know, the need to really improve TB case finding. We know it's one of the largest reasons for mortality in children. And so we really do need to focus on stool-based TB diagnostics and improving TB screening technologies. There was a lot of good points related to improving lab systems and lab data in order to really better serve children. And then, you know, the importance of working with the community and not supporting the community, I think is a really key inference. And then, you know, Lori's comment about the acronyms of OVC, and I wonder, you know, if we even need to change, we need to move from orphans and vulnerable children and coin a different term as sort of we evolve. So just some thoughts. I don't know, Michelle, if there's anything else you want to add that you've seen in the chat as well.
Yeah, great. Thanks so much, Hillary. Yeah, I think there's a lot of great comments that are coming out. I kind of focused in some of the comments with regard to family-centric approaches and how can we really engage our caregivers in a meaningful way, not only, you know, the mothers as well as the children, as we're kind of thinking about this more holistic approach. I really appreciated Catherine's comments about just thinking about the nuances of each population that we're dealing with when it comes to mothers and children, and how we can kind of tweak that approach in order to ensure that we're getting, we're addressing the needs of the whole family, as well as in this quest for continuing to reduce vertical transmission. I think one of the things that came up from one of the discussants I was really interested in hearing a little bit more about is engagement of the faith and community, in this conversation. How can we really plug them in a meaningful way to help push, help us to reach the last mile with regard to getting children retained on treatment. You know, they were very pivotal in the beginning of the HIV epidemic, really helping to fill the gap while we were still trying to figure out what was happening. But through the FCE initiative or FCI initiative that we had a couple of years ago before COVID, we tried to start that re-engagement in the area of, 9 to 14-year-olds in that gender-based violence framework and a part of our programming, but we haven't really talked as much about that within this space. And so I would love to hear if there are any additional comments on how we can continue to engage the faith community in order to help support the work that's being done.
Michelle, thanks so much. And I do encourage people to put up their hands if they'd like to say something. I want to turn it over just for a minute to Dr. Sandy Thurman, to talk a little bit just on the faith community approach. And Tom, I see your hand up, so we will get to you. Go ahead, Sandy.
Thanks so much. And I really do appreciate that comment. The Faith and Community Initiative was really extraordinary. And as you mentioned, the faith community has been a cornerstone of the work of PEPFAR since before it was PEPFAR, and very instrumental in ensuring that we have a PEPFAR program. So we still do partner very actively with the faith communities in all of the countries where we work. And in fact, some of our largest implementing partners are actually faith communities. But we recognize, and we've addressed this in our new COP guidance, which some of you all will be seeing are, planning guidance for the individual countries, that faith communities have been named more specifically as effective partners in our outreach to all communities, but particularly to children and young people. So we were at a meeting just to sort of highlight this in Rome at the Vatican to talk about issues related to children. A couple of weeks ago, Ambassador King Gasong talked a little bit about it. But the women who were there from the community kept reminding us that we keep saying we can't find the kids, we can't find children. And the fact, as she said, they are hiding in plain sight. They are in the churches, they're in the communities, and there's no better way to reach communities in a way that's sustainable than actually partnering with our faith-based institutions. So just know that it is part and parcel of what PEPFAR is and who PEPFAR is, and we will continue to grow that body of work as we go forward. We recognize how incredibly important it is to reach people, but also to sustain programs at the community level. Over.
Thank you, Sandy. And I think Tom might want to add something on that, and then I'm going to turn it over to Anyeka and to Maureen. Go ahead, Tom.
Thanks. Hi, everybody. And yeah, I was going to add a bit, but I think Sandy covered what I was going to say about the faith-based part. And nice to see you, Sandy, and very much enjoyed the Rome meetings. I do think what was clear in that was that the faith-based partners we can work with can actually help across the entire cascade. I mean, I think they can help with the finding part. I think they can help with the testing and linking part. And, I don't want to overlook that the faith-based partners still have a large portion of the health infrastructure in terms of getting kids on treatment too. So that part I think is pretty clear and pretty imperative in terms of crossing that last mile. I wanted to go back briefly on two other points. One, Lori, I hear you on the OVC nomenclature, and we've kicked that around forever. I do think we should probably stop kind of that bifurcation between OVC and children that are positive and on treatment. I think that was kind of the original purpose, was to recognize that as two different issues. But
Actually, they were always together, Tom.
Well, yeah.
I mean in the legislation,
kids that were positive and on treatment they're always OVC, but OVC.
But if we say children, how about if we just say children?
Exactly, that's what I'm getting at. I think we should I think it's really great that children are in there the new strategy as a specific population, and we should talk about children because we have to get them at all points of the cascade. And so thank you, Gretchen. Can we please just go with children is basically where I wanted to end up on that. And the last point I wanted to make, just in terms of the conversation we keep having about HIV requiring more than a medical response, is one that we're still having. And so I just wanted to put in a plug for making sure that we're very specific about what we want to do with the ministries that aren't ministries of health, those ministries of long names and low budgets that do all the work with children and community development and gender. And I think it's clear that the HIV response has built and strengthened the health system, and I think it's doing quite a bit with the social service workforce systems that are out there. But I don't think we get across that last mile without a concerted, specific focus on the social welfare service delivery system and its role in not just in finding children, but in finding them and supporting their testing and providing the support needed to keep them on treatment and attaining viral load suppression. So I want to keep pushing for that. But yes to faith-based organizations, yes to just children, and yes to the social service workforce for me. So thank you. And great to see everybody.
You too, Tom. Thank you. Anyeka. And apologies if I'm saying your name wrong.
I'll give you an A+ on the pronunciation. Can you hear me?
We can hear you.
All right. Thank you very much. I've really been following and enjoying the conversation. It's 4 hours past my closing time. I just wanted to chime in on case finding for children in particular, and some of the lessons we are learning in Nigeria. I'm from USAID in Nigeria. We noticed over time that when we focus on aggregate performance, IPs can very easily achieve 95, 96% well on children. So part of what we've done is to nudge them to develop lay workers and case managers that are assigned only pediatric cohort. It will be family members of the children. That way, we have pediatric targets. And we've seen it begin to move the needles for us. In Q3 of last FY, of the FY, and we noticed a % jump, not only in case finding for children, but also in positive found. And then even at the planning stage, before now, adult numbers, and do an extrapolation for pediatrics. But in our and plan with the specific pediatric prevalence for each age band, and ensure that that number informs quantification for commodities. So that even when we have the commodities rolled out in implementation, we quantify what the children need and is essentially focused on children. And so with that, we now have a you need to do well on the children before your performance metrics can. So that is one thing we've done, at least what is within our manageable control, to ensure that we within the PEPFAR committee in our planning and implementation by IPs.
Thank you so much. Oh, sorry.
All right. Let me rest. I'll put.
Sorry, I thought you were done. But thank you so much for calling in. I know it's a little bit later there. Can we hear from Susuma? Susuma Daniel? Okay, we'll go back to Susuma. Shafiq, over to you.
Yeah, thanks very much, Gretchen. You know, a couple of folks have written in the chat about how to take some of this forward, some of this thinking forwards with PEPFAR support. And one key area that colleagues have been talking about is the support of that community engagement that we all recognize is critical. And perhaps in that same vein, you know, we learned a lot during COVID. Community engagement was actually one of the important lessons learned, but there were others around digital approaches to linking communities and people with their providers. You know, I think it's time that we thought about strategically taking a little bit of a paradigm shift, and with enormous tools such as the funding that PEPFAR can bring to the field, to kind of innovate around some of those ideas and bring them more rapidly into the space. Because I think not only will they build resilience, but they actually, in some cases, improved our efficiency, were better for engaging with patients in meaningful ways. And I think that those are really important outcomes that we should be funding and building into what we continue to do over the next 9 years to get to the end of 2030. So just trying to take it to a practical level.
Yeah, no, very good. That's great. Listen, I want to turn it, I see Maureen's hand, Susuma's hand, and Sindhu's hand, but I want to turn it back over to Hillary and Michelle, and just to see whether there's anything you guys want to pull out of the chat box in terms of themes and ideas that are coming up.
I think people are echoing the themes that are being spoken. So why don't we go over to Maureen?
Perfect. Go ahead, Maureen.
Thanks very much. And I was listening to how we want to engage health workers and talking about other supports. But in most cases, we always forget the primary partner, who are the women living with HIV. We have had PMTCT programs that leave women living with HIV at the consumption level. They're just recipients of services. I'll give you a small example. In Kenya, during COVID, we had stockouts for diagnosis for children. We didn't have diagnostics for children, and we didn't have prophylaxis. And so some of the children went through the antenatal clinic, the postnatal clinic, and they completed all their vaccinations without being diagnosed for HIV. So as an organization, we felt we need to find out, we need to map out the women living with HIV in their different platforms, in their safe spaces, and find out if their children are diagnosed and link them to diagnosis. Unfortunately, so many of them, from the young women and girls, are seroconverting. They are HIV positive. But we don't have the resources. We are doing it on voluntary basis because every time you seek for resources for children, you are told it is within the PMTCT grant. Yet we know that the system sometimes, because of the challenges, miss out on quite a huge number of children. So I think women living with HIV are a really, really strong ally. And we can leverage our experience to encourage other women. And apart from that, we can find the women whose children are not on care and bring them back to care. We also need to ensure that we are speaking to these women before they're pregnant. When we start talking about prevention, once women are pregnant, it becomes really difficult. So every woman in the world should know that they are vulnerable to HIV, and should they seroconvert, this is what should happen. Should they get pregnant, this is what should happen. So it is the PMTCT information is an information that should be available to every woman, like we have on wearing sanitary towels. Thank you.
Thank you so much. And Warren, in the role of women, and as Yogan Pillay put in the chat box much earlier on, working with the families, right? Working with women, working with mothers, fathers, everybody in the family who's living with HIV. I'm going to turn it over to Sindhu Ravi Shankar.
Thank you. All really wonderful presentations and really wonderful points that have been made so far. I'm grateful to be part of this discussion. I popped this in the chat, but I just wanted to mention again, I think another area that would be really important strategically is to strengthen some of the data and surveillance systems. I think we spoke a bit about some of the programmatic data, which of course is really, really important, but we've also seen the impact that the consensus around the 95 targets, and as we're also talking kind of about epidemic control, how that's had an impact in terms of advocacy and resource mobilization. So I think it's going to be important to have this kind of data for children as well. So strengthen the surveillance systems to have 95 data and other data for children living with HIV. And importantly, we've also been talking a lot about granulated data. So, there's a push to get subnational data, to get city data, and sometimes even within cities to kind of get neighborhood level data. And I think that's going to be really critical in showing, and first of all, we know this, but just really demonstrating that there's been a huge gap in serving our population of children living with HIV. And there are several countries that might be close to reaching the 90 or have reached the 90 and 95 targets. But when we're really talking about, the 10 or the 5 getting these data for children will really demonstrate and I think help to mobilize within the countries and within the subnational context as well as kind of mobilize the resources and the programming to make sure that children are not being left behind. Thank you.
Thanks so much, Sindhu. And I want to, I don't know if Susuma, you had any luck with being able to speak? Okay, so I'm going to turn it over to Hillary and to Michelle to kind of walk us through some of the key points that they're hearing in the chat.
Thanks, Gretchen. Yeah, no, I mean, so much information that we will not be able to do justice for in this session, but we definitely are going to save the chat and can definitely follow up. As Gretchen said, this is the initial discussion, not the final. But I think there are a few good points that maybe haven't been said already in great detail. One from Angela Mashavi about really needing to capacitate health workers so that they do meet our women and children where they are and really are mindful of the needs that they have. There was a comment about all the measles outbreaks that have occurred in many African countries, and just sort of points to the issue of challenges we have with the health systems that really aren't reaching children. And so in order to really address morbidity and mortality in children, we really have to improve the health system. I think this really speaks well to Dr. Nkeng's 5-year strategy and his 5x3 pillars. And then I think, we haven't talked a lot yet today in this group about some of the issues related to stigma, but I think we hear that all the time. And I think, trying to come up with good ways to address that specifically for children and women will be really important. I'll turn it over to you, Michelle.
Yeah, great. Thanks, Hillary. Yeah, I'm still digesting a lot of the comments that are coming through. I think that one thing that's resonating with me was a comment that was made around early education for women and how we can sensitize women before they get pregnant on, what HIV means and what they need to do, what are the follow-up steps, the processes for not only if they unfortunately seroconvert, but also in terms of prevention, and really upscaling that dialogue, I think is really important. And so trying to understand ways where we can strategically put those conversations in place with whatever visits that they are, engaging with, I think is important. And how can we leverage other PEPFAR platforms that engage young women, particularly, AGYW, who are at high risk for getting pregnant at an early age. How do we start those conversations at an early age and ensure that they have access to the prevention methods that they need? And then outside of that as well. So I think that that's something that is definitely resonating with me and some of the comments that I'm seeing. I'm still looking through a lot of it, so I'll come back later with some more.
Maybe I can just also chime in about, there's a couple of comments related to community-led monitoring, and I think we're still sort of trying to figure out how to make that really serve to the needs of children and mothers. So it would be great, to hear if people have ideas related to that as well.
Great, thanks. So while people kind of get their thoughts together about that, I'm going to turn it over to Molly. Give us her remarks. Go ahead, Molly.
Yeah, thank you. Thank you, guys. I have a bunch of remarks. Some of them pick up on different topics. I think one of the topics, it's around trying to test and find kids, or case finding. And I do think that while we're getting to a point that some kids are hard to reach or hard to find, we also need to have data that demonstrates that they are hard to find and that they're not within the reach of our programs. And so that means that how many missed opportunities are we having in index testing at our sites that we're not really completing? And we don't really, I think, have as accurate information about index testing as we probably should have. And then there's a second group of kids who are out there that are positive and we have identified them as positive, but they have not yet been initiated on treatment, and they have not been initiated on treatment for a while. So it's not like they're within that 3-month period, but they're known positives. They've been identified, but for some reason, whether there's a caregiver reluctance or whatever issues are going on, these kids are out there, they're known positives, they may be being tested multiple times, we don't know, but there's a need to really understand what that subpopulation is. In some countries, that may be a significant number of kids that are out there with a known status, but yet not on ARVs. And so these are the kids that we really also have to try to identify and figure out what are the factors that are delaying their treatment initiation. And this ties into an important topic that Hillary mentioned, which is the factors of stigma and discrimination that affect access to services for young children, and how the stigma and discrimination factors affecting women, and particularly, and then young mothers in a specific way, are in fear, are affecting access to children, to services for younger children. And so I think when we work on stigma and discrimination, I'm not sure in the broader picture that stigma and discrimination and the sort of trickle-down effects of stigma and discrimination in adults and its effect in children are really being focused on head-on. And one way of trying to help, although it's at the end of the cascade, is really building the capacity of our primary frontline caregivers and parents to support them in getting the best services for kids. So I think really parenting is support for improving and supporting parenting services and training and empowerment, both of fathers and mothers, is really critical for our programs, because those caregivers or caregivers that are non-biological are the ones that are in the front line and have that vested devotion to the care of these children. So we have to capitalize on that. The other thing I think is that all of us here are the known people that have constantly been talking to each other, and we have to engage others in this conversation, folks that are working in the adult treatment and care platforms, where we have to start introducing or magnifying the messages that they have to give adults who have children about the care and access to services that their children need. So those are some of the things that I was thinking about as I'm hearing others talk as well. And so figuring out how do we engage our adult caregivers into providing these services for families is important. That's it. Thanks for the platform, Gretchen. I appreciate it.
Thank you so much, Molly. And, you know, one of the things that has come up in the chat is sort of these thinking outside the box on case finding. On the one hand, we know we're not there yet even with index testing and finding children in terms of it just being a routine thing where we find those kids. But I think it was Mina who pointed out earlier that even when index testing is going well, children have a lot of chaos in their lives. They may change caregivers. They may be very transitory. Their biological parent may have died. And so we also have to think about what are the ways that, and data-driven ways, absolutely, that we can find children who may be not in the situation where we're going to link them to a biological parent through the clinic. Great. So I want to note that we want to give a little time to Eleanor to help us think through some of our recommendations for the plenary. But before we do that, just want to check in one more time with Hillary and Michelle to see if we're missing anything in the chat box, or we're ready to move on to our recommendations.
Some of the key things that I'm noting that we didn't really dig into too much with regard to the data systems and ways in which we can improve that. I think that that's something we'll need to unpack a little bit more, ways in which we can get information that is meaningful to help inform our programming. And then also with the lab diagnostics, this has been a key issue across countries that we've seen in PEPFAR countries, and ways in which we can continue to improve upon and expand, point of care testing, as well as even HIV self-tests. How can we utilize some of these diagnostic tools to be able to reach women and children in a more meaningful way? So I think those are some other things that I'm seeing there.
Fantastic. Hillary, anything to add before we move over to recommendations?
Maybe just one other point that I wanted to come back to, because I think, there's been a lot of talk about, how can community leaders really take over, and what would that entail? What are the nuts and bolts of that? And I think Shafiq made a great comment that, have our country-based leaders, serve as the lead of these global groups, and then we can have regional TA structures and systems to support countries. And I think that they are going to try to do that with the Global Alliance, but really, we want to also hear from our community leaders what would work for them as well.
Wonderful. Thank you so much. So what we're tasked with, which is going to be challenging given all the great ideas and all the notes that Michelle has been collecting, is we are charged with reporting back in plenary what we've been sharing. And Dr. Eleanor Magongo from Uganda is going to help us with that. Eleanor, can you hear me? Do you want to just say hello for a minute?
Yes, I can hear everyone. Thank you.
Wonderful, wonderful. And Michelle Zavilla, when you get a minute, can you show us the plenary slide that we're going to be feeding back to the group? So really what it is that we'd like to go back to this plenary, which will start fairly shortly, and come up with some key ideas. I know we're not going to wrap this up by the time our session ends today, but I did want to just let you know that is the plan. That we will, oh, look at this. My goodness, you guys are so on the ball. It looks like our breakout room is actually closing. Well, we may not have a chance to share this with you before, but you will see it in the rapporteur session. So Eleanor and Michelle, thank you so much for pulling this together.
Thank you.
All right. Well, it has been a great conversation. Thank you all. And thank you to our guest speakers, Helena, Angela, and Shafiq, and everybody who contributed today. I think this is just a really exciting step for children, and to see equity as the first pillar in the strategy and children specifically called out is phenomenal. So thank you again, everybody.